Morning, ladies. Hello.
Morning, Shaida.
Hello. Who's talking?
Shaida, can you hear us?
Yes. Can you hear me?
Yes.
Okay. Shall we start or shall we wait a little bit for more people to join us?
I think let's give it 5 more minutes.
Okay, that's
Thank
fine.
you.
Can you maybe just, I've got an electronic version of the program, Miriam. Is it Miriam speaking?
Yes.
Okay. I want to share that one. Is that okay with you?
Okay, I'll stop sharing and you can share
Okay.
from your side.
Yes. Right. So 5 minutes.
Yes.
Shall we go, Mariam?
Yes, you can start, Shaida.
Welcome, everybody, to the first day of the training as set up for the by the National Shelter Movement in Note that Mariam is the host, I'll be the co-host, and this workshop will be recorded. I hope that more people will join us as we go along. Thank you for making the time. Also, I just want us to be aware of the fact that we have load shedding process and hence the recording process, because that's just one of the things that we have to cope with at this point in time. So thank you. Just wanted you to see my face so that you can actually see I'm not a robot. So thank you very much. I will be sharing with you the program shortly. More people are coming in. Okay. And hopefully this will be a very participatory workshop. And please feel free to ask questions and engage as much as you can. Right. So I will share with you. Okay. That is what the program. Can everybody see that?
Yes, we can. Thanks, Shaida.
Okay, thank you. So today is day one, 21st of July. We'll be doing some welcome introductions and just the orientation as we're doing it now. Then we will start off with a bit of a reflection and just discussion around the topic of GBV and substance abuse disorders or substance abuse challenges in the shelters where you're at. We will have a formal presentation in terms of understanding.
Sorry, Shaida, can you speak into your mic? It keeps going soft.
I am having earphones in. Let me just.
It's perfect now.
It's better now.
Yes,
Okay.
thank you.
So if you can just see there, then from 10 to 12, we'll do a presentation on understanding substance abuse disorders, doing a broad overview, and also just the understanding of, what are substances. Then 12 to 1, we'll just do the whole levels of treatment and intervention so that one can just contextualize it. All right. Then we want to the second right. So day 2 will be specifically talking to the gender-based violence and substance abuse. We will specifically look at women and substance abuse, looking at some causal factors, risk factors, and the link between GBV and substance abuse, and just referring to some research findings and facts. And then also looking at guiding women in recovery, some of the assumptions, patterns, and special needs of women. And then, of course, summary, evaluation, and closure. Okay. Is that okay with people? Right? So, can we just kind of do a quick check-in so that we can just get to understand who is participating. I like to do that. And in the sense of just knowing where people are located. So you introduce yourself, just basically who you are in terms of also your job that you do there and just the particular shelter that you're at. Thank you. Can we start with Mariam? Mariam?
Thanks, Shada. Good morning, everybody. This is Miriam Mangera, the project coordinator from the National Shelter Movement in Gauteng. Thanks.
Okay, thank you. 27761. Who is that? Okay, shall we move on? Okay. Kathy?
Good morning.
Morning.
Sorry, I've only just managed to join. Are you wanting to know who everybody is?
Yes, yes, please do.
Okay, so my name is Kathy Cronje. I am the director of the Safe House Shelter in Western Cape, and the director of the Safe House Shelter in the Western Cape.
So, thank you so much, Kathy, and welcome.
Thank you.
All right. All right. Next one.
Morning, everyone. My name is Rudo Mahusa from Malimartin, Pretoria, Bronco Strait. Thank you.
Are you, Rudu, can I just ask you, are you a social worker or what is your position there?
I'm a chief social worker.
Okay. Thank you so much, Rudu. Welcome, welcome.
Thank you.
All right. Next person.
Good morning.
Mariam?
Morning, everyone. My name is Noluthando Ngcwele from the Haven Shelter in Natal. I'm a social worker. Thank you.
Okay. Thank you so much.
Good morning, everybody. Can you hear me?
Yes. Can you hear me,
I'm
Mariam?
Mariam Fredericks. Yes, and I'm Social Services Manager and Supervisor at the Saki Bapan Center, and I have a colleague with me.
Good morning, I'm Olivia. I'm one of the relief workers.
Welcome, Olivia. Nice to meet you. Thank you.
Morning, everyone. Morning.
Good
morning. My name is Slindi Lezondi from Abrina Esther House. I'm the general manager. And yeah, thank you.
Thank you. Welcome, Lindiwe.
Morning.
Lindiwe.
Morning, everyone.
Good morning.
Morning, my name is Nolu. I'm a social worker at Ilita Labantu in Western Cape.
Welcome.
I'm managing
manager there. Okay. Ilita Labantu. Ilita Labantu.
Yes, Ilita Labantu.
Thank you so much.
Morning, everyone. Good morning, everyone. I'm Gail. Gail Schreiner. I'm the social work manager at Kerr House in KZN in Durban.
Welcome, Gail. Thank you for that. All right, next person.
Morning, everyone.
Good morning.
Morning.
Yes.
I'm Tutuzile Sikudla, auxiliary social worker at Grace Victim Support Shelter in Mpumalanga Nelspruit.
Did you say social auxiliary worker?
Yes.
All right. Welcome. Is it Dudu?
Tutuzile. Yes.
Good morning, everyone. I'm Chandim Pene from Lisa Institute for Women's Development, I'm a social auxiliary worker there. Thank you.
Put your name there, please.
Tanji Mfene.
Sandy. Okay. Yeah. Welcome, Sandy.
Good morning, everyone. Good morning, everyone. My name is Lindwe Jean. I'm volunteering at the helpline, National Shelter Movement helpline. I'm a social worker there.
Oh, social worker. Right.
Yes.
Good morning, Lindsay, and welcome.
Okay, thank you.
Nakanyuma njengoba midle kumbuve wena.
2771, is that you?
Yes, good morning. My name is Alfreda Holland, and I'm one of the relief workers at Sarki Bartman Center in Western Cape.
Is it Alfreda?
Yes, Alfreda Holland.
Is that you, Frida, with 27761?
Yes, that's correct.
Thank you so much. Welcome, welcome. Okay.
Hello.
Names. Yes.
Hi, good morning.
Good morning.
Hi, good morning. You're speaking to Rachel. I'm from the Sarki Bartman Center, and I've got another colleague here.
I'm a relief worker, Melanie van Eden.
Melanie. Okay. Welcome, ladies.
Thank you.
Nice to see you again, Rachel. Thank you.
Good morning, everyone.
Yes.
Morning. My name is Vuyelwa Somana from Victory House in East London. I'm a social worker.
Can you just repeat your name again?
Vuyelwa Somana.
Vuyelwa. Okay. Yes.
Soman.
You're a social worker.
Yes.
All right. Thank you. Welcome, Vuyelwa. Can we go to Annabelle?
Good morning.
Good morning, Annabelle.
Good morning, everyone. Good morning, Ms. Aida. Good morning, everyone. I am Annabelle Bailey, shelter social worker. Then I have two colleagues.
I'm Apida Peterson, relief worker for Sarki Bartman Center.
And I'm Shimane Edwards, a relief worker from Sarki Bartman Center.
All right, thank you. So we've got a lot of
Morning,
people from
Saida.
Sarki. Morning, nice to see you all again, hey? Thank you. All right.
Shaida, before you start, can I please ask everybody, because there's multiple people logging in on one account, so everybody just to type their name, organization, and email address in the chat for registration purposes.
Right,
Thank
I'm
you.
sure everybody heard that. Thank you so much. Right. Anybody else want to just check in?
Good morning, Deline Roberts, Western Cape rep for the NSMA and also the manager at Sisters Incorporated.
Can you just repeat your name again? Hello, Renee. Is it Renee? Okay. Shall we move on? There is a Suzeka. Anyone else?
Good morning, everyone. I am Cindy Simango from Grip Condo Shelter in Petritif, and I am with Sandiwe Dlamini, who's our social auxiliary worker as well.
Hi, everyone.
Welcome, Sandiwe.
Sandiwe Inkosi. It's a very long name. So we just call her Star. Yeah.
Okay, so we will be gracious today. I'll call her Candy Way. Okay.
Yeah. Thank you, Shahid.
Welcome. Thank you.
Thank you.
Right, shall we move on to the next person? Raise your try to identify who is checking in here. Person. This is Vakana.
Good morning, good morning, good morning.
Yes.
Good
yes.
morning.
Hmm.
My name is Vitana Green. I am a house mother at the Kwanabushle Outreach Center in Utenhage. Good morning, everybody.
Welcome. Welcome. Isn't it Kobeha? Or is it Utenhage specifically? Vakana?
It is actually Kariha.
Kariha.
It's actually Kariha. Yes, yes.
Kariha. Okay.
Yes.
Thank you. Welcome, Vakana.
Thank you very much.
Alright, let's see. Maybe let's hear Mabel. Are you there, Mabel?
Good morning, everyone. My name is Mabel Ramalapani. I'm from Child Welfare Webinar Shelter in the Free State. I'm a social worker at the shelter.
Welcome, Mabel. Thank you for joining us. Right. Okay, let's see. We have Shamima. Identify yourself, Shamima. Right, maybe Shamina's not there. Right. I see something, Victory House. Is there a representative or person there? Victory House? Manisha?
Morning.
Good morning.
Good morning. I'm Dineo Mutau, working at the Porter's House. I'm with my colleagues here, but they are main. I don't know if whether I should introduce them by their name or you guys are able to see them. Maybe they can just wait. Eh?
What are the names?
Should I introduce them one by one? I can tell you video. Hello.
Of course, you can do that.
Akibon, matfakago. Oh, start a video.
Okay. You think there are some challenges there? Right. Cindy Seaway. Are you there, Cindy Seaway? Is there anybody else who would like to just maybe check in or just mention who you are and where you're from? I'm sure all of us are ready to proceed. I just see Dorothea, or someone logged in on behalf on her computer. Is that Dorothea from Turkey Batman? Can you hear me?
Hi, Shayda. It's Rachel here. We logged in from our computer, yeah.
Okay, okay. All right.
All right.
No problem. Okay. Pazika? Alexia 812. Can we just get the sense of who that person is? Okay, no response there. Manisha?
Shaida, salam.
Yes, walaikum
Fazika
salam.
sent a message that her mic is not working. So she is
Okay.
present, but her mic is not working. Thank you.
No problem. Thank you, Mariam. Fundo? All right. So, Shamima, are you there? I'm just checking in.
Good morning. My name is Namfundo from Great Eka Shelter. I'm based in Nelspruit. I just got in now. My network is kind of giving me challenges.
Okay, no problem. Thank you, Namfundo. Nice to see your face and welcome. Right. Okay. Let's see. We have, so nobody, is there someone from Victory House that is representing Victory House? Okay, ladies and gentlemen, I would say also, welcome for those who have joined us later. We've gone through the program, which is divided into two today, and we're looking at, the whole topic around gender-based violence and substance abuse or substance use disorders. We will be specifically spending today around looking at the understanding of what substance abuse is all about. I think it is very clear that, within the shelters and even in the sector, GBV sector, that substance abuse there is a reality that can't necessarily be kind of separated from GBV, and that there is clearly more and more evidence that there is a link between the two. I often refer to it as the interface. The third component that I primarily kind of also engage with in my work with women is that of mental health, women's mental health issues. Right? So clearly we have GBV, we have substance abuse, and we have mental health concerns or disorders that is the interface. It's coming into the focus in terms of the work with women. Very, very pertinent components that one cannot ignore. I suppose, in shelters, that is also a very particular concern. And I suppose that is the reason this whole objective or the purpose why the national shelter movement is thought is relevant for us to start engaging and talking about this. Right. So, in terms of the program process, I would like us now to do a bit of a discussion on this whole issue about GBV and substance abuse, and what are some of the challenges that you have in the shelters where you are working. Yeah, I would like us to be very, I would like people to participate in this because, it is a reality, it is a problem. We have problems with service providers, accessing services for substance abuse. And the question is, do you incorporate it into your program or you outsource it? What can you do about it? Okay. So, the key question basically then for us is to look at for you to share some of the challenges for, with substance abuse when your clients or the women are admitted to the shelters. Did everybody get that question? Right. So, shall we proceed? Is there anyone that can respond to that? Can I ask Miriam, Fredericks, what are some of the challenges that you have in your shelter? I'm now just refer to people.
Shaida, we're having a bit of a challenge at the moment with the sound. It's breaking up quite a bit. What question did you ask? Challenges?
I asked what are some of the challenges that you have in the shelter, you know, around the substance abuse challenges.
Okay. As you know, we actually quite fortunate in that we have a substance abuse unit. So we have 10 beds presently. We are full at the moment. But the other issues are the fact that many of our clients have obviously also been using alcohol. Now, in the substance abuse unit, we admit people who are addicted and mandrax. We do not accept anybody with heroin or cocaine, and we also don't accept people with alcohol because we don't have a detoxing facility. So the people in the shelter, we do struggle with that a little bit. And one of our main rules are if they do go out and they've been using alcohol, when they return here, they will be exited. So that can be a problem. But we've had fantastic response from Sanka. We do refer the clients to Sanka while they're here, and it really works very well for the people using alcohol. As you know, with substance abuse, there often is mental health issues, and it's that we struggle with. Often clients are admitted and they don't reveal at the time that they have got mental health issues, and then we struggle with that because we don't have a qualified nurse. The only nurse we have is working in the substance unit, and according to GSD, is not supposed to deal with the shelter clients. So there are challenges that arise, and then there are. I think it's becoming more and more common where people are being admitted who are on Schedule 5 and Schedule 6 medication for mental illness. And that does become a huge challenge for us. And as you can imagine, this also gives rise to disagreements with people, and then they have the mood swings or whatever. Huge challenges do arise around those.
So they could have maybe withdrawal symptoms, eh?
Yes, yes.
So you're talking
That's right.
about, Miriam, just to clarify, you know, the whole issue about, the women who are admitted struggling with substance use or abuse, there is that risk of them going into withdrawal or just having, withdrawal symptoms. Then, of course, the consequences of that, where you have people having some health challenges, né? Whether it's mental health or physical health, and then accessing those components, which often is not necessarily provided, on site. Ne?
And
That's
then
what you
also
say.
there's the extra challenge of mental health services in the country at the moment, I must just say to you. We're
Yeah.
having great difficulty having people admitted, having people even admitted for the 72-hour observation is a challenge. Even getting people to the hospital, it's reliant on our transport, which isn't often available. We only have one driver at the moment for 120 people. So you can see these huge challenges. But as I say, it's something that we need to live with because more and more people are coming in with mental health issues.
Yeah.
And the difficulty is also many of our staff are not trained as such, but they do try and equip themselves with the knowledge, So we share a lot of that, and this kind of training that you're doing at the moment, I think is going to go a long way to assist in that way. That's how we have so many of our staff attending today. So thank you for this.
Thank you so much, Miriam.
Yeah, Shaida, maybe any
Yeah.
of the others? I mean, Rachel has had lots of experience
Yes.
being a house mother and being here for so many years. Or anybody else would like to comment or even add more than what I am? Thank you.
Yes, yes. All right. I think what you also just maybe summarizing what you said, Miriam, is that whole issue about, accessing is one of the key things, secondary services, né? That because as we know, women have special needs, right? Whether it's mental health, and mental health is a key challenge at this point in time, as well as substance abuse, but to sometimes for your clients in the shelters to access secondary or complementary services, right? So that also brings us to the whole notion of the need for a comprehensive almost service that's required, né? Okay.
Yeah,
Thank you,
Shaida,
Maria. Yeah.
I just wanted to add also is the challenges for the children as well. And maybe Annabelle would like to comment here. She's been dealing with the children in the shelter. So more and more we're having to access additional services, like you said,
Yeah.
At the local hospitals, at the Children's Hospital, Red Cross, and even at, oh, I forget the place, besides
The
Safe Land, other
specialized
places that can
services,
go.
yeah.
Yes,
Okay.
yes.
Sure. Thank you, Miriam. Anyone else from Sarki Bartman that quickly want to just maybe add to what Miriam has said?
Hi, Shaida, Rachel here.
Thank you.
Hi.
See you.
Yes, obviously, with the first challenge would be if on the intake would be obviously the withdrawal symptoms with the clients, but before that, at intake level, the honesty of on what drugs they are. They need to be willing and able to be in a program, because if you come to our department and you're not honest about what you're coming for and not willing to be in the program, it's actually not going to help you. You see what I'm saying? So yeah, so that would be at first be a first challenge, and then if you're in the unit, accepted and in the unit would be the withdrawal symptoms, and also sometimes the clients don't understand each other, and then there would be a lot of conflict between the clients. That is also sometimes a challenge, and then another main thing would obviously be the health challenges, and also getting them into secondary services at hospitals where someone desperately need assistance for in-house program at the hospital, and the hospital won't be able to assist us. Then we have to come back with the client. That is quite challenging and difficult. We really need help in that.
Sure. Thank you so much, Rachel. I think that is very useful information, especially the first one that you're talking about, is that level of motivation, into terms of why, what motivated the client to come in the first place, right?
Yes,
and of course, upon admission, you obviously do your drug test, right? And
testing,
then
yeah.
you discover that there's a maybe
that's true.
multi-level, what do you call it, polysubstance use or abuse, and which either fits or does not fit with the admission criteria, right?
Oh, yes, that's right.
And I think that also just adds some challenges there. And of course, admission criteria is very important when it comes to dealing with substance abuse or incorporating substance abuse services in your shelters, because substance abuse is a very kind of specialized program that needs to comply with norms and standards, according to the for inpatient or treatment. So well done. And then of course the withdrawal symptoms, and that honesty of the client is very important, because that will also anticipate and predict the type of drug the person is using will anticipate the possible withdrawal symptoms, right? And
Yes,
of
that's
course,
right.
and part of the conflict could be as a result of the withdrawal. Right, and of course the complications of health challenges that goes often with substance abuse. All right, so thank you for highlighting that, Rachel. Well done. Anyone else want to comment on maybe some of the challenges that you experience in your shelter when it comes to the women that you admit and all their children, and the challenges with regard to substance use or abuse? Delian, Kathy, Rudo, anyone?
Hi, sorry, what was your question?
My question was, let's share some of the challenges that you experience in your shelter, you know, from women who are admitted and the struggles with substance use or abuse. Is that clear?
Yes, sorry, it is. So I think the biggest challenge, sorry, I'm driving, so I can only hear bits of it. The biggest challenge that we have, a lot of our ladies have actively used drugs when just before they've come in. And I think I heard somebody from Saki saying the honesty of the woman. They need to be honest about what they're on. They all think that they won't get in if they've been using, but we take people, even if they have used, as long as they haven't taken cocaine or heroin. But they are not honest with us with what they on, what they have been taking, and it is a challenge for us to try and figure it out and to watch them withdraw, knowing that they've been on stuff but not quite being sure what they have been on.
Sorry, Kathy, does that kind of, how does that interfere with maybe the management of your client in the shelter? Does it interfere with that admission process, or does it interfere with the management of the client while she is in the shelter? Can you just elaborate on that a bit?
So I think we've had cases where women have come in so high that we actually can't do the intake. So we leave the intake until the next day or so, but also the management of the client. So the area that we're in, and it's just demographics, the area that we're in, we're very close, like Saki Bodman, very close to a gang and drug infested area. And unfortunately, over 50% of the clients that come to us are active users. So yes, it does affect the management of the client, although because we've had to deal with it for the last 7 years, we are starting to build it into the management of the client. We know that for the first 2 weeks, that they're not going to be able to join programs. So we've had to adjust our programs and the management around the fact that over 50% of them are active users.
So it's a big challenge, eh?
Absolutely, in our area, absolutely.
Yeah, and I think we will deal with that on day 2, specifically looking at the whole thing around why women use drugs, but also how they initiated into it. So that would be a very useful conversation to have, hey?
So I have a lot to say on that topic.
Okay.
Because a lot of our ladies, didn't want to do drugs and allegedly have been forced. So we'll talk about that tomorrow.
Very, very much. Not tomorrow, next week Thursday, Kathy.
Sorry, next week. Sorry, yes.
Okay, no problem. But thank you for sharing that very useful information. Well done. Okay, anyone else? Maybe Vatana, Nolu, Rudo.
Okay, I'm
Rudo.
Vitana here.
Vatana, yes.
All right. I can also add to what the other ladies were saying about the withdrawal. When our clients came in, our substance abusing clients, they come in and they display a lot of withdrawal symptoms. Yes,
Yes.
they are not eating right. They always seem
Mm.
to find a substitute for what they have been using, maybe excessive use of cigarettes, and then
Yeah.
they are so restless and so roaming, and to such an extent that our other clients now has this fear of this particular
Mm.
client, so they don't want to
Mm.
be around that client. They are also like restless because of the restlessness of the specific client. They don't sleep, man, and they are always up and down. And also health wise,
Mm.
you kind of fear as the staff, because you see how their bodies are deteriorating. They are not
Yes.
gaining any weight.
Mm.
Their eyes in the face gets dark
Sure.
and it gets ugly. So
Mm-hmm.
yeah, it's kind of fearful. It's fearful for the
Mm.
staff to see how they are actually deteriorating, while we so much want them like to progress. Yeah,
Mm.
so that's the challenge that we have. Luckily for us now, we have a nurse again, so hopefully she will be able to know just what complementary service should be should be able that we need there for this
And use, yeah.
particular client. Yeah, yeah. So that is it,
You
Shahida.
know, Vatana, you know, you're raising very important issues here. You know, the whole thing about, you know, that disruptions.
Yes,
Sorry.
yes.
You know, disruptive behavior, you know, which is often also
Mm-hmm.
linked to the fact that the client is maybe actively, was actively using, you know, prior to admission, you know, and
Yeah.
of course the withdrawal symptoms. And I think, you know, sometimes people are very, how can I say, impatient, you know,
Yes.
about coping and managing that withdrawal symptoms of clients, you know. It is a very
Yeah.
difficult factor, a challenge actually to manage, but also it
Yes.
can be, as Kathy and Rachel also said earlier on, that, you know, sometimes if the client doesn't disclose that they've been on maybe heroin, or, you know, it can have very kind of dire consequences, right? And it can
It
actually
is.
disrupt not just the client group, but the whole organization for
Mm.
that matter, because, you know, hence the fact that those particular drugs, heroines particularly, the person needs to go into a formal structured detoxification process, which
Mm-hmm.
requires some medical interventions, and
Mm-hmm.
you know, so it's a high level of intervention required there. So if your facility is not, if that's part of your exclusionary criteria, which basically means that you don't have the capacity nor the resources to manage that
Mm-hmm.
particular withdrawal symptom of that client, it can have dire consequences for any organization or shelter for that matter. So very
Yes, yes.
importantly, and the fact that the client is also, you know, as you say, you know, not eating and their behavior. So there's behavioral, there's emotional, there's physical. There are many kind of factors, you know, consequences that needs to be managed properly, you know, in order for this person to, you know, settle down into your facility. But can you see where already we're starting to see the need for that coordinating part of that service, né? Or to manage substance abuse per se within the
Yes, yes,
shelter
of course.
context? You understand, it's not like a haphazard, oh, by the way, kind of thing. It is something that is a reality. It's something that it is also has become, from my perspective, a special need for services for women specifically within the GBV sector as well. All right, does that more or less summarize your input, Vatana?
Yes,
Okay.
yes, of course, Shaira, you're right on the spot. Yes, yes.
Okay, sure. Thank you so much. Maybe just one last person so that one can just maybe get a sense.
I wonder if I could come in.
Who's that?
Gail?
Gail. Thank
Yes.
you. Welcome.
Just with regards to the clients that we sometimes admit in our facility, when they don't disclose the drug addiction, or even if they do, it creates, I think the previous speaker had already said that they also have behavioral problems with the client. It becomes very disruptive in the sense where you have other people in the facility, and we don't want to have certain allowances or certain rules for some clients and they're not for other clients. So we have to have consistency even within our shelters, because we often pick up that there's huge behavioral problems with drug addiction and the likes. And then the other thing is that we're not trained in this, so we don't know anything about this. Usually if they are on any form of substance, we usually ask them to go and sort that concern out first before we could then cater for their needs. The challenge is that most of these facilities that offer rehabilitation is very often not available, or they cannot take the client at that point. This then puts the client at further risk because there's abuse happening or whatever. Very often it is self-inflicted because they become difficult and they become disruptive themselves. So there's behavioral problems with them. And then when you bring them into the shelter, it just causes chaos. And we don't quite know at this point how we will overcome this particular issue.
So, Gail, are you saying that, yeah, the whole fact that some of the clients who are either using or abusing substances, it does cause or contribute to behavioral problems, right?
Yes.
That in itself then impacts on the chaos or crisis can contribute to a crisis or chaos situation in the organization or shelter rather, right?
Yes.
And the challenges are that some of the staff members don't quite have the capacity, the staff as well as the organization. Can you see on two levels here?
Yes, definitely.
Talking about the Gail, right? So your staff not having the capacity to deal, and when I say capacity, I mean you're not trained, you don't have an understanding of what substance abuse is all about and how it affects the person's behavior, and of course how that needs to be managed. And then of course the second level is that of the shelter per se, in terms of whether you have any policies and procedures how to manage that. And as you say, you need to have one standard kind of rules that accommodates everyone, and not to have special rules for special people.
Exactly.
But it becomes a treatment management problem generally, right?
Yeah, correct.
Okay, so I think those are very kind of factors that, and sometimes a crisis happens any time of the moment, and as you know when you have this kind of volatility and amongst the clients where there's that constant conflict or argumentation or whatever, or fear or mistrust or whatever, it can actually just kind of interfere with the whole program, your treatment program per se. So does that maybe allude to the fact that there is a need to either incorporate that kind of specialized or services in your organization, shelter, hence the fact that you also said that access to external substance abuse source resources is not always accessible and available?
I would think that there needs to be a plan, whether we actually incorporate that within our gender-based violence is probably debatable, because you have different you have different needs here. You talk about substance, which is one particular category, and you have, and then you have women who come from a very traumatic background, already been abused and so sometimes these service users who are drug dependent become abusers within our shelters, and that in itself we cannot tolerate. We cannot tolerate misbehaving or disruptive behavior. We have a very, very strict policy within our structure where if clients don't conform to the rules and the regulations that we present to them on intake, we don't tolerate any disruptive behavior. It gets dealt with very quickly, and also because we can't set a standard that allows beneficiaries of services to abuse our staff or to abuse other residents. Because we have to bear in mind that the clients that we work with already have a lot of challenges. They already have a lot of trauma that they have to deal with. And then when you get someone like that come in, it just disrupts everything. So my answer really is there is a need, but whether that need has to be within our structure, I'm not so sure. I think we need to debate that even more.
Sure. Okay. And I suppose, yeah, you know, it is about best practices in terms of where it's needed, how it works, and but I think the key point is also about the fact that you know, the substance abuse has become a reality or a factor that interfaces very much with GBV. And also what you mentioned now was the whole issue around, you know, trauma, you know, so the substance use or abuse can be a form of coping mechanism, right?
Yeah.
For them to manage that. Did you hear that, Gail?
I get that. But I think there needs to, maybe what we need to think about is a stepping stone towards focusing on the trauma that they experience. So deal with the coping drugs as a coping mechanism, as an entity, before they come into a shelter like ours. I don't know. That's my take on that.
Sure. No problem. I think what's important is that we've come to, maybe part of the conversation is that, you know, substance abuse is a big challenge, right, to manage within the shelters, and that there is a need for that particular service to be provided for the clients, whether that service is on-site or off-site is debatable. Is that what we're saying? No?
Yes, correct.
All right. Thank you so much, Gail. I think that was a valuable conversation there. Any feedback on this matter? Because I would like to conclude this conversation. Right. Any comments, feedback, last insights on this matter? All right. So I think what we basically also just want to highlight some of the key challenges that we highlighted in this kind of session is that, you know, that substance abuse is a reality. It is a challenge, you know, and that clearly it is something that cannot be ignored, because it does affect the operations and work with your clients in shelters. Access, you know, to services, whether you call it secondary or complementary services, is definitely required, right? And some of the challenges are that some of these complementary services are not necessarily part of your program. It's not on site, and the fact that it's not necessarily always available or accessible, externally, has become more and more of a challenge, particularly mental health and or just general health access resources. The issue around staff capacity and for staff to understand what the effects of this substances can have on clients, right? The of a challenge. It does have an effect and impact on both staff as well as the clients, the rest of the clients, and it can contribute to crisis or conflict. Also, the fact that we're talking about, the need to, whether to incorporate this kind of service in your organization, the shelter or externally, and that it requires further conversations around that. So I think it's something that we have to engage work further, and hopefully maybe after day two, if you maybe you can decide after day two, or at the end of day two, as to how you actually, just take responsibility to have further conversations and discussions. So that is within your. I think the
Hi,
point
Shadow.
is,
We can't hear you properly.
really, I think this network is really painful. But anyway, can you hear me now?
Yes, thank you.
Okay, sure. I suppose we were just summarizing the whole thing about, substance abuse and GBV, and particularly in the shelter context, that it's become a reality, that it can contribute to many challenges there, specifically managing the clients in terms of behavior, the withdrawal symptoms, also to look at some of the consequences that goes together with substance use or abuse, and that is health issues, mental health issues, and also the need for particular other complementary services, and then also the whole discussion around whether this kind of service can be integrated into your existing services, or it must be something that can need to be established off-site, but the question is about accessibility. How easily is this accessible? Okay, does that kind of summarize things more or less in terms of this conversation? Miriam?
Yes, thanks, Shaida. Thank you.
Okay. Oh, is it Miriam and Mariam? So I must now just be clear. One is Miriam and one is Mariam. Okay. Is that it? All right. Miriam, so Fredericks, you saying that kind of captures this conversation?
Yes, I think so. That's quite clear.
Okay,
Thank
sure.
you very much.
I think it's very, for those of you who joined us later, I just wanted to show you the program. Okay. What we will be talking to today. And now we will go into the presentation in terms of understanding substance abuse or substance use disorders, and often also referred to as SIDS. All right. And we have, kind of pitched the whole presentations on substance abuse, on different levels, okay? Just to orientate you around the whole content of these presentations, okay? So we will start with the introduction, and it's like a broad overview, right? For us to understand this whole topic around substance abuse, it is much broader than what we think sometimes, so we will look at it from, the scope of substance abuse, having that kind of broad overview. Then we will bring it down to, the types, in terms of what is substances, we're talking about the types, effects, the stages, why people use substances and causes, because I think, if you understand the context or the etiological factors linked to substance use, abuse, or addiction, those are the three different levels, it might just kind of help with that capacity issues that we were talking about, right? For you to get, sometimes if we understand something, it might make things a bit better to manage it. All right. And then also, if time allows us, we'll also talk about, the different levels of substance abuse or treatment or interventions, because I think that will also then help you to, when you have that challenge in your facility, right? In terms of someone either using, abusing, or addicted, you need to know exactly, what level of intervention is required. Okay. And say, for example, I think, was it Gail who said, that sometimes, you need to refer the client, or you need to delay that intake of the client. But it could be a particular contractual agreement with the client that you say, okay, we will admit you in on that particular time on condition that maybe you attend either an early intervention program. You understand what I'm saying there? And then, that would actually maybe also help with the management of the client internally, if the client has had some form or level of intervention already. Okay. And then, of course, also looking at the whole treatment process and aftercare, but particularly the continuum of care model that we use in the substance abuse treatment programs. Okay, so that's just some kind of outlay of how we will actually proceed through the process, because I think what we're saying is, first we need to understand what the substance abuse is all about, and then we're linking it to GBV, how those two interface, right? And that is what we will workshop on the 28th. So just to get us into the next presentation, I have actually invited a substance abuse or SIDS. I refer to him as a guru, or as a very competent person. Can I just check if Devin is in the room?
Good morning, Shaida and colleagues. Yes, I am.
Okay. Thank you. Okay, Devin. I'm just going to introduce Devin. He is a colleague of mine. He is also a person who has had quite extensive experience and knowledge in the field of substance abuse. He can introduce himself further in terms of all his accolades, but I think very pertinent to note that, he is also a board member of the Central Drug Authority in South Africa, board member, and he will be doing that presentation around understanding SIDS, and just do the kind of introductory and overview. So Devin, over to you. Thank you very much. So can you just further introduce yourself in terms of who and what you do?
Sure. Thank you so much, Shaida. I do appreciate. Shaida, while I further introduce myself, I see that I cannot share my screen to
Okay,
open the
I'll do it.
presentation. If you
I'll
can
do
just
it.
do it, then I'll appreciate. Thank you so much, Shaida. So, colleagues,
Okay.
good morning. It's really, it's an honor and a pleasure to be with you this morning, and just to be part of this process. So I am a social worker by profession, and I'm currently in private practice. And I specialize in substance use, or substance use disorders, if you call it nowadays. I used to work, yeah, for the Department of Social Development here in the Western Cape for a number of years, and eventually ended up in the provincial office in the substance abuse unit. So yeah, I think throughout my career, I've always specialized or worked within the substance abuse space. It's a service field that I'm extremely passionate about. And then I think approximately 3 years ago, yeah, Parliament appointed me to serve on the Central Drug Authority of South Africa. And essentially, the Central Drug Authority is the highest decision-making body in the country. It's the highest body in response to the South African substance abuse problem. So our job is basically to implement the National Drug Master Plan, and I'll get to the National Drug Master Plan a bit later on in our conversation or in the session. And our task is also to basically just advise the president and advise parliament when it comes to the substance abuse problem in South Africa. At some point, we divided the country, the 9 provinces. So my core responsibilities to support the Western Cape in implementing the National Drug Master Plan, and then part of my responsibility is also to support the Department of Basic Education at the national level when it comes to substance use in school. So that is a little bit more about myself. And as I'm saying, yeah, it's a real pleasure and an honor to be with you here today. So yeah, once we fly to the presentation, then I think we can basically start with the portion of the section that I would like to discuss with you today.
Okay, shall we go,
Yeah.
Devin?
Yes, we
Yeah.
can go, Shaida. Thank you so much.
Mm-hmm.
Shaida, then I would just like you to assist me with, yeah, should there be any questions or any,
Sure.
yeah, then you can just, because I can get quite carried away when I talk about substance abuse, so you
All
can
right.
just indicate, and I won't mind
Okay.
interrupt me.
No problem. I'll sit in. You can go ahead.
So, Shaida, I'm just struggling to see the presentation. I can see,
Oh.
yeah, you have a folder open there, presentations and docs.
Didn't I share it?
Sure, no,
Can you
didn't.
see it?
No, I can't see it yet, Shaida. And it's saying,
Okay, let's go back again. I'll just say, is it this one? Slideshow, introduction, share. Okay, from the beginning.
Here we go.
All right. There we go. You see it?
Yes, there I see. Thank you so
All
much,
right.
Shaida. So I
Pleasure.
think it's essentially important to just first take a look at the global situation when it comes to substance use, and we won't stand very still at this point for very long, but I think it is important that we just provide an overview. And if we take a look at the World Drug Report, we really learned that 35.6 million people suffer from a drug use disorder globally. And I think this number is more now, it increased, because if we look at the figure or the number in 2018, it was 31 million people. So it's definitely more now. And then what the World Drug Report also informs is that people who are socially and economically disadvantaged are more likely to develop a drug use disorder. And I think this is self-explanatory, colleagues, because of I almost have to say, the wide spectrum of vulnerabilities, because of the low socioeconomic status. People that's socially economically disadvantaged are more prone to, I almost want to say, to succumb to substances. And then only 1 out of 8 people who needs treatment services receive it. And I think this number also increased now. The latest World Drug Report was released just now in June month. And I think June month, in terms of a South African perspective, has been declared basically Substance Abuse Month. And the 26th of June is the International Day for Substance Abuse, and or actually against substance abuse and illicit trafficking. And the new World Drug Report usually is released during the month of June. And I think when we think about this, 1 out of 8 people who can access treatment, I think this is a very sad and I almost want to say very unfortunate situation. But now we just need to think about, I almost want to say, the limited treatment options that our people have access to. Yeah, if I can just think about the South African perspective, I do know that there are provinces where There are not even a rehabilitation center. I know for a very long time the Northern Cape didn't have any inpatient treatment center at all. I think recently the Northern Cape, or actually the Department of Social Development, opened a residential or an inpatient treatment center in Kimberley. So I think, and this is just one of the reasons. So there's a wide spectrum of reasons why people have limited access to treatment facilities. And then on average, 1 out of 3 people use drugs, or actually in average 1 out of 3 people using drugs is female. And I think the number is even more or less when it comes to the number of females in treatment. And I think this is self-explanatory as well. If you look at the, I'm sorry to say, the role of the female in the house, and I think especially from a GBV perspective, you would be very known with this. So it's very unfortunate that there's the number of females are very little that actually access treatment, and it's more males that you get into treatment. And I think a very unfortunate situation from a South African perspective is that we are not very familiar with community-based treatment or outpatient treatment. I know organizations like your Senke, organizations like I know currently in the Western Cape, yeah, the Department of Social Development partnered with Badisa to at least get some form of outpatient treatment out in some communities, but outpatient treatment is a very foreign concept. So within South African, people are more used to inpatient treatment. So I think we can go to the next slide. Yeah, and then 269 million people use drugs globally in 2018, and this group mostly consisted of adolescents and young people. And I think yet again, we need to be cognizant of the wide spectrum, or I also have to say the various vulnerabilities in young people, and that's why they form or actually make up the bigger number or the big amount of that number that we see there. So I know we can continue. So then what the World Drug Report also informs is that more people are using drugs globally. There are more drugs and more types of drugs than ever. Colleagues, a few years ago, I've said, because I specialize in the field, prior to COVID-19, I said that we are sitting on a ticking time bomb. And not only from a South African context or perspective, but also from an international perspective. And I think the COVID-19 pandemic just exacerbated, or it wasn't, the whole substance abuse scourge that we see in our communities. And I think that bomb exploded. You probably picked up or saw in the media the recent 7 killings out in the Eastern Cape. And hence I'm saying, I think that we were really sitting on a ticking time bomb, and that bomb exploded. And then that's why I think the current situation with regard to substance abuse is really out of hands in our country. And drug use around the world has been on the rise in terms of overall numbers and the proportion of the world's population that use drugs. A couple of weeks ago, I had the privilege to go to Sweden. In Europe, I attended the World Federation Against Drugs, 8th sitting of the World Forum, and I also presented there from a South African perspective. And I can really say, colleagues, that we are really sitting with the world drug problem. It is not only a South African problem, and I think drug use is really, it's increasing globally at this point of time. I think, Shaida, we can continue. And then what's essentially also important for us to notice that drug markets are becoming increasingly complex globally. And now, I mean, we need to look at the importing of drugs and the exporting of drugs, and essentially the availability of the drug market and drugs in society. And it's becoming, really, colleagues, it's becoming increasingly complex. I sometimes have want to say the privilege to sit into meetings with Interpol, the international police, and also with the police at an international level. And they keep on saying that it's becoming more and more complex to curb these people and to essentially just, I'm starting to say, keep a pulse on the import and the exporting of drugs. And then essentially plant-based substances such as your cannabis and your heroin and cocaine have been joined by hundreds of synthetic drugs, which is essentially your chemical drugs, and this is not under international control. And I think we see this in our own society as well. So I tend to think of it in this way: when people can't get out of the known substances like your cannabis or your dacha or your heroin, people will, I almost want to say, concoct, or they will develop their own substances. So there's an extremely high demand for people to use and to access substances in South Africa. Next slide, Saida. So the international repercussions of drug use remains a global concern. And as I've said a few weeks ago, I had the privilege to go to Sweden, and they this was actually the highlight or the focus of their engagement there as well. And hence we refer to the world drug problem. And colleagues, there on the map, we can see there, maybe it's a bit unclear to you as well. We can forward this presentation, but there we can really see the movement of illicit substances, illegal substances throughout the various continents to and from all over the world. Next slide, Shaida. So communities in South Africa have a very unique background and context, and I think we need to essentially take this into account to really understand the drug use problem in South Africa at an in-depth level. So basically, we need to think about the common social problems that we are familiar with. So for instance, our poverty, our social exclusion, and then I'm of the view, and I mean, colleagues, you probably hold your own view, but I know in South Africa that essentially we are sitting with a big problem related to dysfunctional families. We need to be cognizant of social problems such as unemployment, your inequality, your crime, and essentially your violence and your GBV as well. And I think these are the social problems that we cannot take out of the picture or of the radar when we think about substance use. So it's very important that we need to see substance use in context, and we need to see I almost want to say the link or the interrelation between substance use and other social problems in the country. Next slide, Saida, please. And then essentially, just from a South African perspective, we need to take into account our unique background and our unique context. And I think this is making it difficult to reduce substance use or SUBs in the country to respond to it effectively. I think we need to remind ourselves that South Africa is a developing country sitting with this wide spectrum of social problems. And this is also making it difficult to respond effectively or to just manage the substance use problem. Substance use and SUBs are at the core of the South African social development problems, and I think this stands to reason as well. Many times I think we focus on, and especially when I think about the social welfare context or social development context, we tend to focus on child protection and we focus on social crime, etc. But we often forget that there's still the substance abuse problem as well. For instance, just from a social perspective, many times we'll see that social workers remove children from their primary caregivers, and essentially it can happen that they don't provide the necessary service to the biological parents or primary caregivers, which is most of the times a substance use problems. And with that being said, colleagues, I'm not saying that substance or actually child protection is not, it's very important primary service field, and we need to safeguard and protect our children. But what I'm just saying is many times we neglect proper professional substance use or SUD interventions to our clients. And then the other important thing that I want to highlight is I almost want to say the disconnection between legislation and policies in South Africa. And I think this is also very important when we think about the way we address substance abuse in the country. And then I think colleagues, essentially what would be familiar to us as well is the very difficult political landscape in South Africa. And I think this is also making it important to address substance use. I also want to say from a policy and a legislative framework or perspective at the national level. The legislative context, when it comes to substance use, the most important ones is definitely the Substance Abuse Act, or as we call it nowadays, the Act for the Prevention of and Treatment of Substance Abuse, and that is Act 70 of 2008. And this is the Supreme Act regarding substance use in the country. They are busy reviewing this piece of legislation. The other important one is the National Drug Master Plan. The current one was implemented in 2019, and the implementation will be terminated in 2024. So it's for a period of 5 years. And this is really the overarching policy in South Africa in response to substance use. There was a major shift in policy. So previously, with the previous National Drug Master Plans, substance abuse was deemed a more of a social problem or social development problem. In this current National Drug Master Plan stipulates that substance use is also a health problem. And this is really, I also want to say, really harmonizing, or it's really in synergy with the international school of thought, because if you look at, especially your your first world countries, then they also deem substance use as a health problem. And I think this was a big victory for us in South Africa. And then there's also a national substance abuse policy that is in the process of development. I gave input to it last week, and I think the policy will be implemented within the next month or so. I think it will be signed off by the National Minister of Social Development within the next month, actually the next week or so. And the purpose for the development of this policy is basically just to assist with the implementation of the National Drug Master Plan and X70 of 2008. And then the other important pieces of legislation for X that is also very important when we think of just render substance abuse services is definitely the Children's Act. And one thing that is important, colleagues, that I want to mention is that many times there's this notion of this mindset or school of thought out there that a child that is addicted to a substance is not a child in care of protection. And I disagree with that in a major manner, because a child that abuses substances is still a child in need of care and protection. So many times I get this feeling, and I see in the field that social work or social service professionals mostly focus on children that's abused or children that's neglected or exploited. But usually when it is a child that use substances, then they tend to basically not focus much or very much on those children. And the thing is, because a child that use substances is still a child in need of care and protection, there can still be children's court proceedings with those children, essentially ensure that they access the correct form of intervention. The Child Justice Act is very important as well. So a child that's using substances can be diverted into an appropriate program. And it's not necessarily always, actually always necessary for a child that use substances, I almost want to say, to be diverted into a generic diversion program. For instance, that's being facilitated by the Department of Social Development. There can be specialized programs with a focus on substance use for children that is in conflict with the law. And the Criminal Procedures Act is the other piece of important legislation. And essentially, a person can be sanctioned, or the court can order that the person go to a rehabilitation center when an adult is in conflict with the law, or if there's one or other criminal offense. And I think this is also very important to take cognizance of. Shaida, you can continue. And I think, colleagues, it's important for us to define a substance use disorder. And I don't know if you can still recall, in the 90s, in the early 2000s, we usually spoke about substance use, abuse, and dependency. And I think the previous Act 20 of 1992 clearly defined substance use, abuse, and dependency. But nowadays, we refer to it as a substance use disorder. And I think essentially a substance use disorder is a cluster of disorders. So it's an umbrella term, but we nowadays we talk about the alcohol use disorder, we talk about the heroin disorder, we refer to it as a cannabis disorder. So the term substance use disorder, or the acronym, actually refers to a wide spectrum of disorders. And currently, it is defined as a chronic relapsing brain disease known by continuous substance use despite negative consequences. And we believe, or we say that it is chronic because of the various physical changes and the impact on the brain and the central nervous system, and the management of the disease is performed as with any other chronic diseases. So what the current school of thought at an international level is basically that, it's actually saying that substance use should be managed just as any other chronic disease. So, for instance, hypertension or diabetes or cholesterol, because it's a very complex, it's a difficult a problem to deal with or to respond to, and hence it ought to be managed just as you would manage any other chronic illness. We say it's relapsing because the disorder is relapsing in nature due to various reasons. So, for instance, it's physical complexity, and the environment, and the nature of treatment. So essentially what I would say, colleagues, is that we don't foresee, or we don't plan a relapse, but we just need to acknowledge the relapsing nature of the disease or the problem. And then we say it's a brain disease because it has an impact focus on the brain, and we'll get to that in a bit. Shaida, you can continue. And then we also say part of the definition is that it is ongoing substance use. So there's essentially usually a deep desire to repeat substance use despite the negative consequences. So what we usually see, and I think you see from your clients as well, irrespective of the negative consequences, irrespective of the, I almost want to say the adverse effects or the repercussions in the lives of the clients, they usually continue substance use. And that is, I think, at the point where we usually get very frustrated with our clients. So this is basically, colleagues, how we define a substance use disorder. And the overarching source of this definition is the DSM 5PR that we usually use as the diagnostic criteria or the diagnostic manual to define mental health conditions. And it is also defined as a substance use disorder by the ICD. I don't know if you've heard about the ICD-10 before, the International Classification of Diseases. Some time ago, I checked, and then the World Health Organization was in the process to write ICD-11. Colleagues, I don't know, I still need to check if ICD-11 if it is currently implemented, but the last time I checked, we still use the ICD-10 currently, and those are the two overarching sources or trusted, I almost have to say, instruments to define a substance use disorder. Sharon, we can go to the next slide. So, colleagues, there's basically just a picture of a normal brain versus a substance use disorder affected brain. And I just need to mention, like I said in the beginning, I'm a social worker, and yes, I've done some postgraduate training, and essentially I specialize in the field, but I'm not a medical professional. But clearly, from what you can figure from evidence in sources, is that there is evident differences between a normal brain and a brain that is being affected by substances or substance use disorder. Shaida, we can continue. And then when it comes to the brain and just seeing that difference between a normal brain and a brain of a person that with an SUD, our attention is drawn to the reward circuit that we find in the brain. So basically, that under normal circumstances, so I almost want to say normal function, a normal functioning person, there is a protective layer around the brain that we call the blood-brain barrier. I usually just abbreviate it and remember it is the BBB, the blood-brain barrier. And basically substances penetrate the BBB and they tap into the processes occurring in the brain. Substances therefore directly impact the way a person thinks and the way a person behaves. And colleagues, most research says, so for instance, smoking. Smoking a substance, so nicotine or it can be cannabis, is literally taking between 5 to 10 seconds for the smoke or for the substance to reach or to penetrate the blood-brain barrier. So it's very fast. This whole process is really really occurring in a very rapid way. And the most important part of the brain impacted is the reward circuit, and that is located in the limbic system of our brains. And the limbic system is basically responsible for emotions, it's responsible for feelings, memory, and judgment. And usually we see emotional dysregulation in persons with SUDs. With emotional dysregulation, I mean that the person's emotions usually fluctuate. So there's basically a roller coaster ride. And that's why we usually see that, for instance, within the therapeutic or the intervention environment, the one day the client wants to access treatment and the client is motivated, and the next day, we can even be a couple of hours later, then the client is completely demotivated for treatment. So it's because of this emotional dysregulation in the direct impact of the substance on the person's emotions, the feelings, and the memory, and the judgment. Our brains are wired to ensure we repeat life-sustaining activities by associating it with pleasure and reward, and basically storing of information in our memory. So, for example, eating and sex. So for instance, eating is I almost want to say it's a pleasurable activity. It's something nice to do. And I usually I have a sweet tooth, and I think about desserts whenever I train on this. It's something pleasurable, and this is just how we are wired. So what substances usually do, it messes, or it basically hijacks this reward system of our brain, and hence at a later stage the person associates the using of the substance with extreme forms of pleasure. Next slide, Shaida. Substances stimulate the same reward circuit as I've just mentioned, and hence the experiences of pleasure and reward. And due to the pleasurable effects, people usually repeat the use of a substance, and this later leads to the development of a SUD. Colleagues, and this is very, very interesting, and I would encourage you, if you want to, or if you would like to go read up more about this, and I think essentially we just say for limited, our time is very limited today, but there's various research, extensive research has been done on this. The one example that I can think of at this point of time is, for instance, if you take a look at heroin, or the impact of heroin on the brain, then you would find that heroin is actually locking onto neurotransmitters within the brain. If you take, for instance, or if you think about cocaine, then research shows that cocaine is overstimulating the release of dopamine. And dopamine is one of the our feel-good hormones that we associate with pleasure. So, for instance, if I'm taking a jog, or like I just said, now I have a sweet tooth when I'm eating dessert, or when I'm just having a good time, then there's usually a release of dopamine in your brain. And what research found is that cocaine there's an overstimulation, or cocaine actually activates an overstimulation of dopamine in the brain. So this is very, very interesting, colleagues. So there is, in I'm saying, when you think of substances, there's usually a complete hijack of the brain, our brain's reward system, and therefore there's an inability to control substance use when it usually develops into a SUD because of the pleasurable effect, because of the feel-good neurotransmitters that is being released in our brains. And the pleasure experience in substance use is usually 2 to 10 times more powerful. So, for instance, if you compare substance use with any natural activity, or any natural thing like eating or having sex, or just having a good time or jogging, if you compare it with substance use, then the pleasure that people usually get from substance use is 2 to 10 times more intense. And the effect is usually almost felt immediately. So now you can just fathom, now you can just think why people have this big or youth struggle or difficult struggle when it comes to substance use. And usually the effect is lasting longer than those produced by natural rewards in the life of the person. So this is just a, I almost want to say an illustration. Shaida, yeah, the previous slide. So if you compare natural rewards, like I just mentioned now, sex and or natural pleasures, eating, taking a jog, having a good time, with using substances, this is usually how it looks like in the life of the person. So substances usually dominates, it's more intense, it's much more pleasurable. And now, colleagues, you can just think how difficult it is to reverse this process within an intervention process, including aftercare. It's extremely difficult, and hence they are sitting with a high level, or high, I almost have to say high number of relapse within South Africa and at an international level as well, because it's extremely, extremely difficult to reverse what we are currently seeing on this slide. Colleagues, I'm going on probably like a steam train here, so please, if there's any questions, or if you just any uncertainties or comments, please just indicate. So then I'm quickly just going to give an overview of the criteria for substance use, and we can find this in the DSM as well. So basically, first of all, we usually see that the person will need more of the substance to experience the same level of satisfaction or pleasure, and this is usually because the person is built up a tolerance. That's the word that we usually use, tolerance. So the amount, or the I'm trying to say the extent the person is needing the substance is now much more. So it's usually the first thing that or the first box that we need to tick. Secondly, there's usually or the person is unable to reduce the quantity or to stop use despite trying. And I think what I'm actually thinking is that this is self-explanatory as well. And we see this in the lives of our clients as well. The person usually it's extremely difficult for the person to cut down. Thirdly, the person uses more of the substance or for a longer period of time than the person meant to. So I usually think about the weekend example. So say, for instance, the person was used to just using substances over weekends, and now it can happen that substance use creep into the person's work week as well. So that is where we usually see that it's slowly but surely starting to spiral out of control. experiences cravings to use the substance. This is a big one as well. And there's usually a wide spectrum of cravings depending on the specific substance that the person uses. So it can be that the person is getting agitated. It can be that the person is getting anger outbursts. I've seen, and especially in females, where they start to get teary, or they just have I almost want to say a complete sense of overwhelm. It can be physical as well. So in some sense, there's a wide spectrum of cravings a person or clients can experience, and this usually depends on the substance. It can happen that there's problems in the relationships due to substance use, but persists in the person actually persists in using it. And I think it is especially with this one where violence in GBV is coming in, because there's usually this I also want to say this problem that starts to escalate within the lives of clients. Spends a lot of time on substance use related activities. It can happen that there's a reduced involvement or time spent on social, recreational, or work activities, and this we usually pick up in our assessments. When we do our biopsychosocial assessments, we often establish or ascertain that the person or the client used to be involved in sports or some or other positive life activity, and usually substance use completely interfere with this, and then because of I almost want to say being preoccupied with this, experiencing an increase in substance use and use substances despite the impact on physical and mental health. I mean, many a times medical professionals can confirm that there's liver liver dangers, or if the person is developing hepatitis, or there's some or other physiological impact or repercussion, and usually many people, when there's a substance use disorder, discontinue with substance use, and the problem perpetuates. Next slide, Saida. We'll continue with the criteria. So usually we'll see there's the person is unable to carry out responsibilities expected at work and home, using substances in situations that may be physically dangerous. So here's where we see people drive under the influence. And this from a South African perspective, and this is the thing that we are trying to change at the national level as well. I think we are so fixated to focus on drunk driving, or people driving intoxicated with alcohol. But I think in South Africa, we also need to start looking at drug driving. So what I mean, if a person is intoxicated with one or other illicit substances, or even cannabis as well. And I think this is something that is really neglected in South Africa. Experiences withdrawal symptoms when substance use is stopped or reduced. And I see many times we see this in our clients as well. Many times we will find that we don't have to start an informal intervention process. Usually during assessment, a client can indicate that I'm really trying to reduce my substance use, or I've tried to stop, and then it is important for us to be cognizant that the person can start to experience withdrawal symptoms. And colleagues, just on this one, the two dangerous substances when it comes to withdrawal is alcohol, and it is heroin. It's it can become very dangerous. So I think we just need to be cognizant of this. When our clients are alcohol users or heroin users, I would advise that the person get or access medical care as of day one, because a person can actually die from alcohol and heroin use. Crystal meth or tuk, not so much. It can be that the person needs detox, and I think that is really depending on individual cases. But I'm very cautious when it comes to alcohol and heroin. You probably heard about cold turkey before. Cold turkey, especially in heroin users, where heroin use is usually stopped. And then it can be that the person starts to experience shivers, the person can experience convulsions, they begin to sweat, etc. So alcohol and heroin is I must have to say, the two most dangerous substances when it comes to withdrawal. So what we usually see is when two or three of these criteria is in the life of the client, we usually classify it as a mild level of a substance use disorder. When there's 4 or 5 of the criteria present, it's a moderate level of substance use, and when there's 6 or more, the person usually needs intensive intervention, and then we classify it as a severe level of substance use. And then, colleagues, I think something that is not on the slide that is important that we also need to assess is the addiction process. So usually we'll get the pre-dependency stage of addiction. There's the early dependency stage, and then we usually get the critical states of addiction, and then the chronic stage of addiction. In these criteria that we just went through basically harmonizes with the whole addiction process. Next slide, Saida. And then we'll quickly just go through the various reasons why people use substances or begin to use substances in the first place. The first one, and this is I almost want to say a big one in South Africa, currently living in or lived in a dysfunctional family, like I made reference of earlier. I think in South Africa, we actually have a problem related to dysfunctional families, and this really includes adverse childhood experiences as well. Colleagues, and I don't know if you can still remember some of the theory from undergraduate studies, but the first 6 years in individual or the child's life is very important, and I think it's in the very I think psychology speaks about this as well, where the foundation is really laid within the first 6 years of a child's life. And when there's usually adverse childhood experiences, like the things we see in our clients and out in practice, then this is usually a big, I almost have to say, indicator or big probability for substance use disorder to develop at a later stage in the person's life. Or actually past traumatic experiences and trauma never dealt with. I think there's various research, extensive research being done, or that have been done on trauma. And when there's undealt trauma, this can actually be, I also to say, a vulnerability for the development of a SUD, pre-existing mental health disorders. This is a big one as well. Many times we'll find that there's some stigma attached to mental health disorders. So people usually, I mean, there's no management of bipolar or depression or schizophrenia. And this can actually be, the substance use can be a coping mechanism for just to cope or to live with mental health disorders as well. Personal environmental factors, and I think we spoke about this earlier on, your poverty, the unemployment, all the GBV, violence, or the other social problems that we encounter or find in South Africa. This can be a huge vulnerability for the development of a SUD, inability to deal with peer pressure as well. And I think this is very much important when it comes to the adolescent population. And I think when we quickly think about theory, the adolescent population or the stage of adolescence, it's identity crisis. I need to find my feet. There's abstract thinking, etc. So this is I almost want to say it's a very vulnerable season in the life of a child or a young person. And this can essentially lead to the development of a SUD. And then the last one there, a sense of belonging, especially related to gangsterism and the circle of friends. And this is a circle of friends, and this is very common amongst boys and men. There's a big sense of belonging, which can essentially lead to the development of a void in the person's life, and this can lead to the development of a HUD as well. Next slide, Shaida.
Okay, Devin, I just wanted to come in here. Maybe we can just pause for a minute and just check in whether there's any particular questions from people, or if you want to just maybe lead that process, and then maybe just to take a break for people, because they've been going now for 2 hours. Yeah. Would you like to maybe just check in with people whether they have any queries or in terms of your presentation?
Thank you so much,
Thanks.
Shaida. Definitely. Colleagues, any reflections, any questions, any differences of opinion, that's welcome as well. Any
comments, yeah,
on what we presented thus far? Comments?
Hi, Denver and Shaida, everybody else. I'd like to comment very quickly just to say that I thank you very much. You really do, you know your stuff. Shaida said that from the beginning. So this has been marvelous. I just want to comment on that last thing, the sense of belonging. I think in the last 15, 20 years, I mean, I haven't looked at research, but it seems that this is becoming very common amongst the girl child and the women as well. If you look at the high schools, the girls are becoming gang leaders even. And we even see it amongst some of the client population or community that we're admitting at the moment. Girl, child, and females are also becoming very, very active in gangsterism. Thank you.
Oh, thank you so much, colleague, for that comment. And I agree with you. Yeah, it really, yeah, it's I just want to say it's spilled over, it moved over to the girl child as well. So thank you so much for commenting on that. Colleagues, any other thoughts or any other reflections or questions before we go into our break?
I just want to, if I may, thank you, Devin. It's a very enlightening presentation. I'm really enjoying it. I just want to ask you, what is the prognosis of someone who use crack cocaine and meths together and their ability to relapse?
Sure. Thank you so much for that. Can I quickly just ask for how long are the person using substances?
For a number of years.
Sure. So what I usually prefer to begin with is just I almost want to say a thorough biopsychosocial assessment. I don't know, Shaida, and I don't know if you have tools, colleagues, but I can perhaps after this training email some tools because there's a really, I have a very good assessment tool called the Maudsley assessment for substance use. That's usually my starting point, to just do a thorough biopsychosocial assessment, if I can put it that way, and basically just determine. So there's also this term that we call recovery capital, and we'll get to that a little bit later. But usually I look for, I almost like to say, any form of strength or any positive factor or element in the person's life to essentially strengthen that person's recovery. So I think it will determine from individual, or it will depend from individual to individual. But usually with crack cocaine and crystal meth, there's a good probability for the person to make a full recovery and to actually sustain his or her recovery.
Thank you. Thank you.
Can I also maybe just add there, Devin, if you're okay with that?
Definitely, Shaida.
Yeah, thank you so much. I think, we're highlighting that whole thing around the strength of the client. That's very important. That also includes the family, that resilience factors that we often look for. What are those kind of strengths and support systems and structures in place that can help this person through that recovery journey. And so resilience is something that we kind of look for, tap into, maybe untap or establish, within the family system and or community system. Thank you, Devin. I don't know if you agree with that.
Most definitely, Shaida. And thank you so much for raising that point. Yeah, thank you. Colleagues, any other thoughts, reflections, questions, comments? It looks like we are covered, Shaida. So I think we
for
can.
Now, yeah.
Shaida, did you suggest a 10-minute break?
Yes, I just feel like, so that people can just kind of, comprehend the information, and maybe just to reflect, and maybe when we come back, we can maybe some people will have more questions or comments, and then maybe just to recommend a 10-minute break. Is that okay? Is that okay with you, Devin?
It's perfectly fine with me, Shaida.
All right, so we will return back to the room at about 10 past 10. Thank
morning,
you. So
all.
please, yes, who's
Hi,
that?
morning, Shaida. It's Melanie. Hi, how are
Yes.
you?
I'm very well, thank you.
Sorry, I
Melanie.
just stepped in from my other meeting. Sorry about that.
Okay, all right.
Thank you, Shaida and Devin as well. If I can please just remind all to register on the chat, the name and name of organization for attendance purposes. That'll be amazing. And yet again, thanks, Shaida and Devin, and we will see you all in 10 minutes.
Okay, so maybe if I can just ask Miriam if she's still in the room to maybe pause the recording and then reset it once we're back in the room. Is 10 minutes okay?
Yeah, Miriam has actually stepped out. I've taken over from her.
Okay, so if you can just do that recording, just to pause it so that there's not too much of a pause in the recording. Hey,
No problem. I shall do that.
Okay, so maybe I just want to check in with people and participants. Is maybe 10 minutes, or would you prefer 15 minutes? Because when we come back, we will go straight up and just have like intermittent, maybe 5-minute breaks if necessary. Any recommendations there?
10 minutes is perfect.
Okay, in a second. I need someone else to just confirm that. What do you say, Melanie?
10 minutes is sufficient. Perfect,
All right,
Shaida.
cool. We'll be back
Thank
at
you.
10 past 10. Thank you.
Hi, Shaida. I've started
Hello,
recording
welcome.
again.
Thank you so much, Melanie.
Pleasure.
Given, are you back in the room?
I'm back, Shaida.
All right, please continue. Thank you.
Sarah, can you just open up the presentation again, please?
Okay. Can't you see it?
Now I see the
Okay.
folder again.
All right, let me just see. Let me just go to that slide. Number 8, right? No. Let's go further down. Okay, here we go. Can you see that?
We can see it, Shaida. Thank you so
Okay,
much.
pleasure.
Colleagues, so when it comes to substance use, the circle of courage is of utmost importance. So it's very pivotal. It's really important that we have such a comprehensive understanding or thorough understanding of the circle of courage. And I don't know if there's social workers and social auxiliary workers that can still remember the circle of courage, but basically the circle of courage derives or originates from the Indians that used to, that actually originated in America. And the Indians, many moons ago, believed that there are 4 critical areas of development in a person's life. And those 4 areas are belonging. So basically, each and every human being should have a strong sense of community. The person should learn to love others and basically just being or forming part of a community. Then we have something we call mastery. And essentially, each human being should learn to master certain things in his or her life. So the person must get competent to a large extent in his life. The person needs to learn self-control, basically take responsibility, and basically to strive to achieve personal goals rather than superiority. The third component of the circle that is very important is independence, and this basically means that each and every individual must learn to become independent at some point in his or her life. And then the fourth component of the circle is generosity, and that basically this means to live in harmony with other people, to be generous to a certain extent to other people. So the circle of courage is extremely important. I know many moons ago the ACVV, the ACVV, they used to assess their clients based on the circle of courage. So they will used to look at all of these areas, and then they would essentially make a determination or come to certain conclusions about a particular client based on the circle of courage. I don't know if ACVV still do it, but I can still recall that they used to assess clients based on the circle of courage. And I think like I just said now, when it comes to substance use, the circle of courage is of utmost importance as well. So I'd have the next slide, please. So within substance use context or substance use paradigm, in the circle of courage, it can happen that the person have a certain void or desire to belong. And this desire can be deep-rooted. And like we discussed earlier on, it can happen that it originates from early childhood experiences or adverse childhood experiences. It can also be that the person might be challenged to master certain tasks in his or her life and did not reach key milestones, for example, schooling. And I think we see this very much in the lives of children with fetal alcohol spectrum disorders. Usually you get FASD children, they roam around in the community and they, for some or other reason, dropped out of school, say for instance, for academic reasons or an inability to cope with academic work. And if that can happen, then that person succumbs to or excess in use substances at a later stage. It can also be challenges related to independence and making decisions in your own best interest. And here we are reminded about peer pressure that we alluded to or discussed a little bit earlier on. Challenges related to generosity, for example, making a contribution to society, helping others in essentially finding meaning in living a productive life. And many times, clients will indicate this or say this to the therapist or to the counselor that they have the sense of hopelessness, meaninglessness in life. They don't know where they're on or off. They don't know how to move forward. And it can happen that the sense of hopelessness, or I must want to say lack of purpose in society or meaning in community or in life lingered around for a very long time. And if all of some of the components in the circle are not in place, we can refer to the circle as an unhealthy circle or broken circle or dysfunctional circle. And I think this is very important when we work with people using substances. And I almost want to say, in my experience, 80% or at least 80% of clients that use substances usually is a unhealthy or broken circle. Then we're going to move on to the manifestations of emotions and behaviors in people using substances. And I think the very important one that we will start with is ambivalence. And basically, ambivalence means simultaneous and contradictory feelings in the life of the person with the SUD. For example, a desire to recover on the one hand, and on the other hand, a very uncomfortable or actually comfortability of continuing the use of substances, like I also alluded to earlier. It can happen that the person has a strong desire to change, and the person actually embark on the process or can see a professional person to embark on a journey of change, but on the other hand, it's extremely and very difficult for the person to change. And that feeling or that, I'm starting to say, emotion or behavior that we see, we usually refer to it as ambivalence. The second one is tolerance, and this happens when a person needs a higher amount of the substance to achieve a desired state. So in practical terms, I usually think of it in this way. Say, for instance, you get a person using alcohol. It can happen that way back when the person started using alcohol, we used to drink 1 or 2 beers over a weekend. And then at the later stages, the person move deeper into the addiction process, and as the substance use disorder progress, the person can find himself drinking I also have to say, a 6-pack of beers, or a whole, say for instance, 12 or even more beers or alcohol. So there's that gradual increase or need to increase the amount of the substance in the person's life, and we refer to it as tolerance. The next one is this, and I think this is a very big one and something that we need to take cognizance of. A lot of internal distress that is happening within the person using substances. So basically, this means all the feelings related to the SUD and emotional processes taking place in the person. So, for example, the person's fears, the hopelessness, the depressions, and in many instances, I really see that people are getting anxious. So there's a lot of anxiety. It can happen that a person feels that there's no hope and that they are in this deep, dark pit of depression. And we see a lot of internal distress, internal, I almost have to say emotional turmoil in the life of a person with the SUD. And then there's something we call the principle of Peter Totter, very strange name. And this basically means that the person who is using the substance will essentially get sober after using the substance and must face reality. And I think when I think about Peter Totter, I am reminded of a seesaw. So essentially, for the one person to go up into the air or up, the other person must be at the bottom or down. And for the other person to go up, then the other one needs to come or needs to go down. And this is basically a very, I almost want to say, the same thing that we see in the lives of people using substances. So it's almost like they can have this thinking that they can remain or stay intoxicated forever. And then essentially within the therapeutic process, I almost want to say it's a very hard reality that they are coming to when they realize that they can't stay intoxicated forever. At some point of time, they need to sober up, and they need to, I'm sorry to say, the substances need to get out of their body, and they need to face reality, whatever reality is for them. We see a lot of denial in people using substances. I don't know if you've heard the acronym before, usually, or in the substance abuse service space, we usually talk about don't even know I am lying. Don't even know I am lying. Usually we see that clients using substances, I almost want to say many times they are so far removed from reality, and they I almost want to say that they keep on telling these lies or untruth things to themselves, and they can find themselves in a web of just denying a lot of things. And this is also a very sad thing when we think of people using substances. And then the last point there's usually a lot of emotional turmoil in the life of the person. And it can happen that the person experiences various adverse emotions and doesn't know how to deal with these emotions. And I think there's this overall sense of overwhelm. And I think it's very important for a person rendering a service to be aware of these emotions and behaviors that the person using substances experience or go through, so that we can essentially be in the correct position to render the correct form of support to the person. So now I want to pose this question to you. If I offer you 10 million rand today, wherever you are in South Africa, and I ask you to just, listen, or just basically adhere to this one condition. You need to go to the airport before the end of the day. We see that plane there, British Airways. I give you 10 million rand to transfer to your account, but the condition is that you must leave South Africa to never return back home again. You can't take away your spouse or your partner. You can't take away, or actually cannot take with your friends or any significant other essentially in your life. But you must leave the Republic, or you need to leave the country today. 10 million rand in cash or in your bank account, and you need to, here's your plane ticket, and you need to leave the country today. You'll never return, and you never have to have contact, or you cannot have any contact with any significant other back home. So this is the question. So if one or two people can perhaps just give their views, would you do it? Wouldn't you do it? Will it be a difficult thing, or will it not even be a thing to consider if I have to give you this offer today? Yeah, maybe one or two people, if you can share your views.
Even I must say, I'm sure at this point in time, a lot of us would want to take that 10 million, with load shedding. With load shedding. Sorry, that's not just a bit of a joke.
Yeah.
Any comments?
Now I get you, Shaida. I get you. Any comments? Any thoughts about my offer of 10 million rand and to never return again? And you can essentially go to any other country or any other place that you would like to go to.
Okay. For me, 10 million rand is not merely enough for me to just drop everything and go. So no, as much as we need it, but no, I wouldn't take the offer.
Okay. Thank you. So there's a decline of my my beautiful offer. Thank you so much for sharing your view. Any other thoughts on this, colleagues?
Devon, I would also decline, as much as that offer does sound pleasing, especially like Shaira says, with the load shedding and coming from lanes, we've had no water also now for 2 days. It's definitely a pleasing offer, but then you think of leaving family and friends behind and never seeing them again. And also, like Sindiswe says, it's 10 million, but this 10 million really get you far in another country, especially looking at the value of our rand.
Yeah. Maybe a third person that wants to say his or her views on my generous offer. It's been declined 2 times now.
Hello, sir.
Yes.
Yes, I feel that I would also decline because from where I'm sitting, my family is more important than money. We can starve together. I think it is better that way than being away from one another. Thank you.
So now, thank you so much, colleague, for sharing your view. And then I just see here in the chat pane, Gail is saying, I would be tempted to go to my daughter overseas. So that is how, that's Gail's view. Gail, thank you so much for sharing your view. Shaira, I think we can go to the next slide. And just to put it out there, colleagues, I don't really have 10 million rand, right? But, so I think, yeah, this is a very good analogy to use and to think of when we think about the process of change or intervention in the life of people using substances. And I think many a times I am being reminded that this is basically what we are asking of a person to just leave the substance or become sober, which is of course extremely difficult to them. And not in any way, I almost want to say sugarcoating the substance use in itself, but I think many times we find that the person use substances for so long, and it basically I almost want to say in many instances the substance became almost like a significant other to the client. And this is essentially, yeah, as I'm saying, the analogy that we just use. So we basically, it can feel to the using person that we are asking of them just to pick up their life, give up their lives here, and go stay in another country. And just, I almost want to say, leave their current context, their friends that they are using with. Remember we spoke about the sense of belonging earlier. So basically just give up this domain or part of their lives and transition and into a completely different life. And it can almost feel for clients as if we are asking this of them. And as I'm saying, it's an extremely difficult process. And I see time and again, case after case, client after clients. And some of the things that they usually go through, so usually we'll see that there's a lot of fear and anxiety for this new life or for this new found sobriety. And this fear and anxiety can be related to, first of all, coping without the substance. And this is a big thing to clients. I know in some rehabilitation centers or inpatient centers, they ask clients to write a love letter, or not a love letter, a farewell letter rather, to the substance of their choice. And I've seen some of these letters. And if you read that letter, it's almost seeming like the person is divorcing a partner, or basically someone, a significant other died or is in the process of dying. And then I think when you think of it in this way, when you really come to terms and see what clients are going through, then you really understand the extreme difficulty clients are going through when they need to enter a process of change or an intervention process. The fear and anxiety can be related to a new life, a new circle of friends. Where am I going to get new friends? I don't know how to make new friends. These were my buddies that I used for 30 years or 20 years. So there's lots of anxiety and fears, a sense of belonging, basically to use resources. Many times clients don't know how to use resources. And I think in many instances, we are so quick to say, but look, just put yourself in a job market, compile a CV, do some job scouting, just attend your support groups. And these things are not easy for clients to do. It's not easy for them to embark on. Clients many times don't know how to use resources. And we can be quick just to think, okay, just leave this old life and just get sober and remain a life of sobriety. And how to basically socialize yourself in a new way, how to socialize yourself in almost have to say a more healthy way, how to conduct yourself. Usually clients have fears to be rejected by others. I've seen this many a times with clients, especially clients that goes to inpatient treatment centers. I mean, it's not even a couple of hours at home, then the neighbors are skinnering and they are saying, but I wonder when he's going to go walk to the merchant again. Look, I wonder when he's going to backslide again, things like this. So there's a lot of pressure on a person that wants to rehabilitate or wants to enter a process of change. And then it can happen that the person is sitting with a fear to fail, or a fear to just, can I do this? Do I have the ability to do this? And these are questions clients are often confronted with. And many times fears and anxiety can be so intense that it manifests physically. I mean, I saw clients that sitting with full-blown panic attacks, heart palpitations, sweaty palms, becoming lightheaded, becoming dizzy. And then it can really be a very adverse state or very negative state for the client to be in. And usually there's emotional turmoil that we see in the lives of clients as well. And this basically means that there's the old emotions, so basically the trauma, the dysfunction, adverse childhood experiences. So all I also, if I can call it, is the old emotions or the old problems in the life of the client. And then there's the new emotions related to the process of change, the anxiety and the fears that we just discussed. And this situation can really put the client in a situation or state where they are completely overwhelmed. And this is usually a stage where we really need to hold the client and just put that, I also want to say, create that safe space within the intervention environment to the client. And what we usually also, Shaida, did we go, can we have the next slide, please? And usually, so there's this term that we refer to, we call it recovery capital. I think I alluded to, I mentioned it earlier as well. And basically, recovery capital refers to the sum total and the quality of resources that can support the person through the initiation and maintenance of the recovery. So this is basically all the, in practical terms, all the positive things in a person's life that can assist that person with the process of recovery. So we get internal recovery capital, and that is basically the person's personal strength, self-confidence, a positive attitude, the person's willpower to embark on a process or journey of change. We get external recovery capital. That's basically your family support, a person's the family's willingness to support the person in the process of change, education, qualifications, so basically access to opportunities. And then there's physical recovery capital, food, finances, housing, employment, visible means of support in the life of the person. And basically what is important for us to realize is that the recovery capital directly impacts a person's decision to change and how this process unfolds. Now, colleagues, now I just want to allude to the how on earth can we expect a person to make a full recovery from substance use if we don't even have the basic physical recovery capital like food, finances, housing, because of the dire state of poverty in the lives of clients. So this is an extremely difficult situation. And what we usually see in South Africa is that people have very low recovery capital. And this is the reason why we are making very slow progress in the process to, I almost want to say, to turn around the substance abuse situation in our country because of the extremely low recovery capitals that we usually get.
Sounds like Devin has been kicked out or lost connection. Devin, all right, I'm just checking. Okay. Shall we just wait for him to come back into the fold of things? I'm not sure if he's maybe having load shedding.
Hi, Shaida.
Oh, you're back. You're back.
I am back. Yeah, I am having load shedding, so I think the thing my UPS just kicked in. Yeah, I do apologize.
All right. Okay, sorry about that.
Now I
I'll
am
go back
back.
to the previous one. Thank you.
Sure. Thank you, Shaida. Yeah, so colleagues, I can't emphasize or stress this enough. We and as I'm saying, we don't often think of it in this way, but recovery capital in South Africa is really making rehabilitation or the process for people just to embark on change. It's really making it extremely difficult. And I think we somehow need to start applying our minds as to how we can build recovery capital, how we can enhance a person's recovery capital. And I think we can definitely make our clients an active part of this. And I almost want to say many times, I think in my view, we're actually doing our clients an injustice because these are the things that our clients usually don't know because essentially of the lack of knowledge or disempowerment. And I think we as change agents, it's our responsibility, and I almost want to say it's our mandate to allude to this and to make clients understand, or almost want to say to make an analysis of each person's recovery capital and see how we can practically assist the person within an intervention process to basically embark on a journey. I think this is it from my side. So I think before I leave the platform, I would like to hear any comments, any feedback. I know one or two colleagues gave preliminary feedback earlier on to a certain up to a certain point in the presentation. But yeah, maybe just some thoughts or final reflections on substance use disorders, the service field, and essentially what we ended off now, recovery capital in South Africa.
Thank you, Devin, for that. Any comments, please do. I'm just going to stop the sharing now. Please note that we can make this available, Devin, the presentation to people. Okay.
Most definitely.
Thank you. Any feedback, comment? Let's hear from people. Questions even?
Hello.
Hello, Matsepo.
Yes, I'm talking from Bethlehem Child Welfare.
Okay.
And in the program that we have for substance abuse prevention, we are honestly struggling in terms of getting the substance users to be into the rehabilitation institutions. I don't know what is happening in other provinces, but in our province, the process is really difficult because we do not have many rehabilitation centers, especially also for children. And when we look at the rate in which our children are using the substance, I tend to feel that we in as much as we are trying to address it as a problem or as something that has turned to be a pandemic in our country, but we are somehow failing because the prevention services does not balance with the treatment services. And it is my wish, if possible, that there can be an increase of rehabilitation services or centers in the provinces so that the access can be much easier for all the identified service users. I mean, not service users, but substance abuse users within our own communities. Thank you.
Thank you for that comments, Matsepo. Devin, would you like to comment, please?
Yeah, most definitely. Thank you so much, colleague, for sharing that with us. And I think South Africa, I may have alluded to this earlier on as well. We are very much focused as a country still on inpatient treatment. And I usually say that we'll never be able to do away completely with inpatient treatment, especially when it comes to your severe cases of substance use. And I'm now thinking about your dual diagnosis cases where when it's substance use and there's a mental health condition as well. So inpatient treatment will always be needed, and we have to have those in all provinces. But I think, and this is something that I strongly advocate for at the national level, I would like the country to move to a more community-based treatment perspective or paradigm, if I can call it that, because many times community-based treatment, so first of all, it's much more cheaper. Because if we think inpatient treatment, that it's residential, you need medical staff, and you have to do a lot of compliance with norms and standards currently. But if we can have more, I almost want to say outpatient treatment sites or community-based treatment sites, then it would be much more cheaper, and I almost want to say much more accessible to communities as well. You actually, in actual fact, you just need a social worker or therapist to render the service. And then you can just, I almost want to say, integrate or link the service with resources at the local level. For instance, I mean, and I think, yeah, we as social service practitioners, we really, I must say, we're really good in jumping the system, because there was in some communities where I was involved in rendering services where I just had a service agreement or maybe an agreement with a local nurse. And then that person can, for instance, come and do the medical assessments and basically just form part of the multidisciplinary team. And they, I mean, all the communities that I used to work in, then they would welcome that, because essentially it's a health problem as well, and they are feeling it in the health services as well. So yes, it is important, and we are looking at that at an international level. But as I'm saying, I'm really advocating in a strong way to fast track the establishment of community-based or outpatient treatment services.
Thank you for that, Matsepo. Are you happy with that response?
Yes, ma'am, I am happy with the response because yes, the number in the community is so much that it cannot be really handled by the rehabilitation centers that are available. So opting for a community-based treatment, I believe it is an ideal solution towards the problem of this substance abuse in our communities.
Sure, and maybe that's an opportunity for shelters maybe to partner with community-based treatment programs or facilities, or organizations that provide community-based substance abuse treatment programs. Eh? Devin, can you also maybe just comment on that whole factor around, as we know that inpatient substance abuse treatment programs is very expensive. It's a very expensive program, and hence also the fact that there's been, only 10% of clients, need to access that inpatient treatment based on the service delivery model, but also the whole cut in budgets, in terms of funding for substance abuse treatment programs. Is it possible maybe just to give a quick feedback on that?
Sure, no, most definitely, Shaida. But before I get there, just wanna make another comment. So if the colleague they just spoke, if you can just send me, and I've posted my email address in the chat pane earlier, if you can just send me an email, because the Central Drug Authority is really active in the country. And I think, yeah, since we took office, we said that we want to have a hands-on, bottom-up approach. And we essentially told each other that the country consists of 9 provinces. And we want to work closely together with service providers at grassroots level. So we told each other, I mean, we don't want to sit in Tshwane or Pretoria and make decisions there, and then we are completely out of touch with what is happening within the provinces. So I'm just thinking now, there's a representative for each province. So if you can just send me a mail sometime, I can most definitely link you up with the Central Drug Authority rep in your province, and maybe you can just start some conversation with a person supporting your province, in so that you can basically just zoom in on your area and see what services you can get going there. I would really appreciate that. And then, Shaida, to come back to your question. So basically, substance abuse, and like I also alluded earlier, it's still people tend to prioritize child protection from a government budget perspective, tend to prioritize child protection, and a bulk of the budget is going to social crime and all other service fields. And colleagues, I would want to say again that I'm not saying that any of those fields are not important. Yes, it's very extremely important, especially child protection. But many times we'll find that people, it's almost like they don't think much of professional substance abuse services, and this now includes community-based treatment, inpatient, early intervention, awareness and prevention. So basically the whole continuum of intervention when it comes to substance use. So recently we have learned here in the Western Cape that the budget for substance abuse has been cut with 80 million rand, 80, and that is really, it's very disheartening. And it's very unfortunate. And I think for the past 10 years in the Western Cape, the Department of Social Development is really focused on establishing, especially the rural areas, professional substance use services, especially early intervention and aftercare services. So it was really disheartening to learn that the budget for substance abuse services has been cut in the Western Cape with 80 million. I think it has to do with national budget allocations. So we as a Central Drug Authority are busy looking into that. And as you would know, colleagues, with especially when it comes to the allocation of government budgets, there's also I almost want to say political element attached to that, but we are really in the process of advocating, because I know in the Western Cape, many organizations had to let go of their social workers and social auxiliary workers because there isn't enough money anymore. So it's really unfortunate. And I think even if I can even ask this structure to make some noise, and maybe just to start the substance abuse conversation and see how we can essentially integrate substance abuse services or SUD services within the homeless sector, then that would be a great thing.
Sorry, Devin, you mean in the GBV sector, not the
Or
homeless sector.
the GBV sector, Shaida, yeah?
Sorry, but thank you a lot for that, Devin. Would you like to maybe check in if there's any other comments from people?
Most definitely, colleagues. Any other comments or concerns or just reflections on this presentation or this slot of the training today?
Hi, Devin and Shaida. Thank you very much. It's Rachel and Melanie here from the SARC department. Yeah, I just have a question. Involuntary admission. Parents, mothers coming saying that I need assistance with my adult son or my adult daughter. I can see that they are just losing it and they go to the police stations, they go to the courts for assistance. When they get there, then the courts and the police say there's nothing they can do. They come to us as the organization also for assistance to ask what can we do, where can we go to for assistance, because we have our adults, children that really needs assistance in that field, but the courts and the police is not able to assist them. And then also, what about the mother with a 9-year-old son or daughter coming saying that my child is using excessively DACA at school, and the school is referring them to like organizations like SARC department or SANCA for counseling. Yes, they do get the counseling. They test the child when the child goes for the counseling. Child is still positive, come back, child smokes again. So where's the help for that mother? Thank you.
Thank you so much, colleague, for raising this. And according to the Substance Abuse Act, Section 33 speaks to involuntary admissions of people using substances to inpatient treatment centers. I almost want to say it's highly neglected and stigmatized in South Africa. So people usually have this, I almost want to say, thoughts or understanding that the person must be motivated and the person must be voluntary or go to a rehabilitation center voluntarily. And it doesn't have to be so. I mean, it's enacted, it's in the legislation. And I'm at loggerheads with people a lot about this. I mean, personally, I've had clients in my career that came back from rehabilitation centers after being admitted or committed through court. And then they would thank the social worker or thank me and just say, but thank you so much because I had a change of heart. My social functioning is now better. I'm doing better. Thank you so much for actually forcing me to go to a rehabilitation center through court. So I think, colleague, we just need to do a lot of advocacy. I mean, I'm the type of, I will go with the act to the magistrate or to the state prosecutor and say, but listen, the act is saying the following. Because I see, essentially, I think we need to advocate for our clients, but I think the best route will most probably be to speak to the or a local office of the Department of Social Development. And I would advise at least speaking to a supervisor or manager, because I know from a DSD perspective, they work closely together with the local court. And I know that usually there's a dedicated a social worker for substance abuse services in DSD's local offices. So I think that would most probably be the correct route to take. But I would strongly advise against this. I almost want to say just accepting the whole situation as it is, because as I'm saying, it is enacted like that, Section 33. And the thing is, I mean, we can't deny legislation. And usually, just the other day, I've heard when new legislation comes into force, the Department of Justice usually train all the magistrates and all the state prosecutors on the legislation. So I think it's a bit, I almost want to say it's disheartening for them not to take up their responsibility. And I think essentially the person with the issue is he has a right to be served. And obviously the person is in a state of mind where they can't make decisions in the best interest, and hence Section 33. So as I'm saying, I would strongly advise follow the route through the local DSD, specifically with the supervisor or manager, and that can be the I must want to say the access to the court, the magistrate and the state prosecutor. But please don't accept it as is. Colleague, as I'm saying, as I've said a little bit earlier on as well, I've posted my email address in the chat pane. So if there's any further challenges or if you struggle with the local office of DSD, please reach out to me, and then I can definitely see to assist from my side.
Thank you so much, Devin. There's a question from, thank you, Rachel. That's a very valid question there. So we're talking about accessibility, but also highlighting the importance of legislation that guides, that can be used in order to activate clients to have access to services. There's a question from Cindy Siwe and Gail. Can we go with Cindy Siwe? Cindy Siwe, yes.
Yes. Hi, Shaida. I just wanted to second what you said when you said that we should also work hand in hand with other civil organizations who are working to alleviate substance abuse. Because we'll find that with us, we had a case where we had a lady that was admitted to our shelter. She was brought here by DSD social workers. I'm not sure when they were doing their intake process if they noted that she was under the influence or she was addicted. By the time she got here to the shelter, we really had trouble because now the process that the DSD undertakes, the detoxification, applying for a place at the rehabilitation center, it's quite lengthy. So that client was here for a month and she was going through all these withdrawal symptoms and vomiting and all of that. And you'll find that we don't even have, I don't want to say knowledge on how to deal with such, but we basically lack experience when it comes to dealing with substance abuse. And by the time the client left and went to the rehab center, she had undergone the process. It was like she was ready to even just go home by the time she left the shelter. So I don't know if maybe there could be a way where these processes can be shortened. And I know that, yeah, before they go to the rehab centers, they must undergo the 3 days detoxification. And with that as well, when you go to the hospital, they tell you that there's no beds, so they can't detoxify them. Maybe by the day you intake them, you'll have to wait a week for you to find space for them to be detoxified. So hey, it's a problem. And some of them become aggressive. One really, she wanted to kill us here in the shelter, and we're calling the police, and we're not even receiving any assistance from the police. I thought I was going to die that day. It's quite tough.
Yeah, it can be overwhelming.
It's very overwhelming.
Yes, in this way. Tevin, would you like to comment? We can maybe comment, but maybe first you see that you are the key speaker for now.
Sure. No. Thank you so much for raising that, colleague. So the thing is, doesn't it? So first of all, I think there should be liability from DSD side. So I think I don't think it's fair on a shelter to take on or take in a client and then you don't know, I almost want to say, the full background of the client. And I know sometimes social workers can do that, or social service practitioners, but I think there should be a very open, stern communication with DSD so that they can understand. I mean, they can't just, because it can be like, the client said that he or she wants to kill herself. So the thing is, DSD needs to understand that you should be thoroughly informed about I almost want to say, the whole problem situation of the client. Not only stating, okay, maybe there's violence or GBV, but also substance use, because that's very important. And I think that that agreement should be there with DSD, first of all. And then secondly, I think because, it is a very difficult substance or SUD problems. It's a very difficult service. It's a very difficult problem to deal with or to respond to. So I do suggest some future training as well, or maybe some follow-up training, because this, maybe you've heard about this. We call it motivational interviewing, MI. And MI is a specific set of skills that you can implement to keep the client motivated, or to actually enhance the motivation of the client. And that's key, especially in the first stages of the person's recovery process or decision or recovery journey. So I do suggest, so maybe we can start some conversations, Shaida. But there's definitely, I almost want to say, a lot of skills and a lot of tools that you can essentially implement or use to assist a client with the SUD, like in this instance that you just described. But as I'm saying, first of all, that process with DSD needs to happen, and you need to make sure that you're on the same page with DSD, because they can't do things like they've done in this situation. And secondly, there's definitely a lot of skills that you can learn within the training environment to essentially assist the client effective.
Thank you, Devin. As we were talking, I just kind of got this light bulb moment, in a sense that there's definitely a need for capacity building to look at, this whole thing around, depending on the level of where the client is at, whether it's pre-contemplation, contemplation, those stages. But also the whole thing about, in the shelter context, in a situation where that client is in need of some form of SID, SUD intervention, and that maybe, some early intervention programs can possibly be implemented, and considering that whole MI kind of intervention or focus. What is your take on that, Devin? Just to kind of also help to either motivate the client or prepare the client for treatment, and and also to help manage that whole difficulty case. I mean, that scenario that Cindy Siwe has just sketched now.
So most definitely, Saida. I think there's a lot that can be done in the I almost want to say the shelter environment. And I'm even thinking that you would be able to tailor-make, or basically to structure some form of SUD service within the shelter environment that can essentially harmonize with the programs that are that's already being implemented in the shelter. So most definitely, I think it's just a matter one needs to understand the context a little bit better and see I almost have to say the current service needs. And it's my view, yeah, you can definitely be able to design, I almost have to say, a pure SUD or substance service specifically for the shelter's needs.
Yeah, to package almost based on the service needs. And of course, as you say, it's context based, depending on, some provinces are more resourced than others when it comes to the different levels of substance abuse treatment programs that's available, whether it's prevention, early intervention, or statutory services.
Most definitely, Shaida.
And of course, there's obviously that big need of capacity building, to enhance the capacity of staff in order to, either raise awareness and or, incorporate it into a treatment program or plan for that matter. Hey.
Yeah, no, definitely. I think there's a lot that can be done. And I think, yeah, we shouldn't sit with the situation where staff feel like the colleague just described now, feel overwhelmed, or I almost want to say the situation is becoming tiring because of, I was going to say, not having enough services or skills or tools. So it's definitely a conversation that we can have with each other, yeah?
And I think, just in terms of the previous first session we had, Devin, just to give you that feedback, that a lot of comments were made about, how the crisis, that is often centered to the person with the substance use disorder, spills over, into other clients, as well as into the bigger part of the organization. So there's a lot of disruptions, chaos, crisis, things going on, right? And that in itself is that tiring factor that you're highlighting here now.
Yeah, no, most definitely, Shaira. I'm in agreement, yeah.
Thank you so much. Gail, if we can get your comment, question.
Yeah, thank you very much, Aida. My concern is, what is the difference between a rehab facility and a recovery facility? And then also on top of that, many organizations these days can just, or many people these days can just go and open up an NGO and function as a, let's say, a recovery center or whatever, but might not necessarily have the right tool, the resources, or might not have the right qualifications to do this kind of work and cause more harm. And in fact, Devin, I said I would like to discuss something with you, which is really of great concern for me, but I would like to just know, what are the controls that are put in place? I mean, now we're talking about shelters as well, and most of our shelters here have professional people, but we're not specifically trained in managing the drug issue. So how do we monitor a facility that might be a drug recovery center, but don't have they have the willpower and they might have the vision for it, but are not adequately trained? What are the qualifications that those centers require? And also, who monitors them?
Thank you for that, Gail. Very important, right, Devin? So we're talking about compliance, you know, according to norms and standards, registration and all of that. But first, the differences between rehab and recovery facilities, and then, of course, the whole issue around the authenticity of the facility itself. Thanks, Devin.
Sure, thank you so much, colleagues. So first of all, yeah, the Department of Social Development is the custodian, as we know, of all social welfare or social development services. So I almost want to say the registration, in the licensing, in the monitoring of all services falls directly within the context or the scope of the Department of Social Development. It is the mandate of the provincial office. And I know most provinces do have a database of registered facilities and unregistered facilities. So what I usually advise is, as soon as you become aware of a facility or service that is not registered, or you suspect that the services are not registered, please report it to the provincial office of DSD. There's usually a unit within the provincial office that takes responsibility for substance abuse services. Way back in the Western Cape, I used to work in that unit. And as I'm saying, it is their duty, it is their mandate, according to legislation, to basically monitor these services and yeah, hold these people accountable. And this is a very important thing, Gail, because the thing is, many times you'll find, because of the desperation, because of the dire need in terms of substance use services, there is a lot of unregistered facilities. My goodness, I've worked way back when I was still at DSD. I used to work extensively in the Western Cape, and there is horrible stories. I mean, many times you'll find females. I've seen this one center where a female was actually raped by another client that did a sex addiction. So, and I mean, if you can just think process addictions or behavior, we mostly spoke about illicit or addiction to illicit or illegal substances earlier on, but process of behavioral addictions, that's another ballgame. I almost want to say your online gaming, your sex, your gambling, etc. So it's very, very important that centers must be registered with the Department of Social Development. In the reporting takes place when a service is not registered with DSD. Usually the requirement is that there must be at least one I also want to say appropriately qualified and registered professional person. That is usually a psychologist, or at least a social worker, or a nurse, or a medical doctor, but they must be. And I don't have the norms and standards open in front of me now, but that is what I can recall, at least one professional person. Then the other people can be lay counselors or recovery assistants or paraprofessional or lay professional people, but there must be at least one professional person in that. This goes across the whole continuum of services. So this is for early intervention, community-based treatment, inpatient, aftercare, and reintegration. So just to touch or to come to the difference between an inpatient treatment center and a recovery home. So I think, yeah, there's all sorts of words and jargon out within communities or all over, that's being used all over the country. But basically, an inpatient treatment center is a center as we know it. So that's basically, it's residential, and there's a full multidisciplinary team. The client resides there for a certain period of time, and it's completely residential. A recovery home, so in actual fact, according to legislation, we don't have something like a recovery home in South Africa. We call it a halfway house. That is the only, I almost want to say, type of service other than an inpatient center that is being in that you can find in the act. And a halfway house is it's almost like a step down facility. And I don't know how many of you are from the Western Cape, but I know in Cape Town we have Helderberg Omgee. It's out, I think, to Somerset West Side, and I'm not that familiar, included up with the other provinces. but that is basically, it's a step down facility that people can access after completing community-based treatment or an inpatient treatment service. But I think throughout the country, people use various words and pronunciations and things. So basically, it's just an inpatient center and a halfway house. If the recovery home, Gail, is a halfway house and it is registered with DSD, then it's fine. But I know that there's all sorts of things that you get. For instance, in the Western Cape, we have a big problem with facilities that call themselves sober living houses. And you get these places on farms, you get them in Cape Town itself, out in the rural areas. And it's basically, it can consist of a person that is in recovery for a long time, and then the person usually is a couple of other people that is in the recovery as well. And those things, I almost want to say, is very dangerous, because many times, as I've just mentioned, as well, the people do more harm than good. Many times, yes, the intention is good, but I think it's rather best for services to be properly regulated by the Department of Social Development. And I know when services are being regulated, then DSD usually do unannounced visits and inspections and things like that. But I know unregistered facilities and services it's a big problem in South Africa. DSD, very honest with you, sometimes they don't act. So they are supposed to open up a court case and to basically notify the facility or the people that they are in contravention of the service. And they don't do it many a times, but they are supposed to do it, and we can actually hold them accountable.
Thank you very much, Devin. That's very helpful.
Thank you, Devin. Vatana?
Yes, thank you. Just a quick question to Devin, please. I am sensing that most of our shelters are not equipped enough. As I can hear, most of us are saying that we are sitting with clients that we can't really manage, or we can't really help, or we can't really assist because of lack of knowledge, or lack of equipment, or lack of training, of whatever the case may be. So my question is, if someone from my community should come to me for help now, what do I do with my problematic son, maybe my drug abusing son? What can I tell this person? What should the first step be? What are your experiences from an effective first step that could be taken?
Sure. Thank you so much for the question. I think the first step would most probably have to be to access a professional person, which is usually your social worker at the local level, so be it in the NGO sector or DSD, providing services in a particular community, or at least to the local clinic, because so that professional screenings and an assessment can be done. Because remember, two people can use crystal method, and it can be a completely different situation in both their lives. So I think the very first step would most probably have to be to access a professional person, and in this, that is usually a social worker, or at least a nurse at the local level. Because remember, any person that is using substances must be properly, we call it screening. And basically the screening, and there's evidence-based tools to use screenings. I know the one's name is Audit, and then you get the cyst, and all lots of funny names do that you get, and there's 10, there's 20. And all of these instruments are basically screening tools to determine the presence and the severity of the person's substance use disorder. And after that, usually a thorough assessment needs to take place. And based on the screening and the assessment that took place, a person can make a recommendation to say, okay, this is the severity of the person's SUD. So is inpatient needed? Can the person just attend an outpatient program, or maybe just counseling on an individual basis with a social worker? So I think, if you get such cases, I think immediately refer them to at least a social worker or a nurse at the local level. I know sometimes, colleagues, we are sitting in with a dire situation in South Africa, because I know on the other end now the social worker, maybe at the local office or that's working for an NGO, works more generically, and it can also happen that the person doesn't have a thorough and an in-depth understanding of substance use. But I think it's very important in this situations like these, that we have service agreements with each other, and that we can see to access treatment, access trainings, so that we can get thoroughly capacitated to respond to or to render effective services.
Thank you, Devin. Vatana, are you
Thank you, Devin. Thank you very much.
Comment? All right.
Yes, yes. Thank you.
I think, Devin, I know you've got other appointments. Thank you very much for your valuable contribution. Can you hear me, Devin?
Yes, I can hear you, Shaida.
Okay. Um, yeah, I mean, I think it's also important to note those Devin did indicate that you can communicate with him if you need any further questions or want to just make a contribution in terms of maybe matters that he can take up further with the as a representative of the Central Drug Authority. But also just to let you know that Devin is also a private practitioner or service provider in the field of substance abuse, and he is also kind of providing community-based intervention and also involved in a particular community-based intervention program. Would you like to just quickly share that, Devin, so that people can know that they maybe if they need any questions or can comment or access you or even refer?
Sure, no, definitely. Thank you so much, Saida. Yeah, so I am in private practice, social work private practice. In my field of specialization is substance use. First of all, I am based in Cape Town, but I am so yeah. Should you know of people that perhaps need counseling or assistance, I am open to virtual or to remote assistance. And then we are about to start a outpatient treatment service in Wynberg in Cape Town, and this is in cooperation with the Lafim Wellness Clinic in Cape Town. So yeah, should you know of any people, I'm going to say in Cape Town that requires assistance with professional rehabilitation or treatment, they can most definitely access that service here in Cape Town. But just from a private practice perspective, I mean, I am available to counsel families and people using substances remotely and in person. Thank you so much, Aida.
Okay, thank you, Devin. Any just closing comments or feedback to Devin in terms of his presentation and contribution? Thank you. Maybe one or two persons. It seems like people are quite okay now. Devin, so maybe just to maybe just to let you in on the next session, the discussion that we will have, and that is just basically also informing people about the different levels of intervention, which I think will be a nice flow to what you have presented now, and then just also to look at so that people can understand where they can access and the level of intervention or treatment. Would that be useful? Hey.
Yeah, no, most definitely, Shaida. Most
Okay.
definitely. Yeah, and yeah, please invite me to future engagements.
Yes.
And as I'm saying, we can definitely explore
Yeah.
trainings. And yeah, thank you for having me in your space.
Yes, thank you for your contribution, valuable contribution, Devin. Thank you so much, and we wish you well. All right, so thank you, ladies. I know we've been quite busy, so if we can just maybe the next session would be about, that whole levels of intervention and treatment so that people can actually just understand where and the different levels so that you can decide. All right. So thank you. Maybe we can just take a 5-minute break so that people can just maybe have a bathroom break or just body break or something just to stretch or get a glass of water. Is Vatana, you wanted to say something?
No, I'm good. Thank you, Shaida.
Okay, thank you. All right, just a 5-minute break and we'll be back at about, say, what's it now? Say 21 minutes past 12. Thank you.
Thanks, Shaida.
Thank you, Melanie. Welcome back, everybody. Hope we stretched and refreshed. So thank you for your participation. I think, This next section will very much kind of is very informative in terms of, you know, we look at the levels of service delivery and treatment interventions, which would be very useful, because I think, you know, it kind of also resonates with a lot of the questions that came from this previous session around, you know, where and how do we access services, all right, for persons challenged with substance use disorders. And so it will be probably useful for you to understand, you know, the type of intervention that might be required. Okay, so the overview is just basically looking at service delivery levels, and then we're talking about that continuum of care treatment, which is very much part of the whole intervention, treatment intervention processes. All right, so if you look at just kind of looking at the service delivery, just checking if can everybody see the presentation? Melanie?
Yes, thank you, Shaira.
Okay, thank you. You can see it. All right, so we're talking about prevention services, early intervention, and treatment, which is also referred to as statutory, and then aftercare services. So that's basically the different service delivery levels, right, where intervention and treatment can actually take place, right? These are very much linked to the norms and standards, you know, for substance abuse or substance use disorder treatment or managing that problem particularly. It's a very kind of organized, structured, and there's certain standards that is required. So just quickly going on, this is basically where we look at the different levels of service delivery, and this is an kind of a copy of the from the norms and standards, minimum norms and standards for inpatient treatment programs, also developed by the Department of Social Development. So, as you can see, you know, from the outer circle, right, that is where the desired level of social functioning is required. Okay, as now you can make the links between what Devin has been talking about, you know, in terms of where we're at in our communities, okay, and where the person is basically, whether in the family or in the community. So the second level is that of community awareness and prevention. That's the next level of service delivery. Okay, and then early intervention, right? Okay, and then there's the statutory residential kind of level, which includes that of treatment as well as reintegration. Okay, reintegration basically means the way the person goes back to this initial level, the desired level of social functioning. Okay, so, and as we know that or per discussion with Devin, is that this statutory residential kind of service delivery level is a quite a difficult one, in a sense that you know, this is very limited. It's a very costly event or situation. It requires very kind of strict requirements, compliance, registrations, and you know, this, it's quite a kind of a lengthy process. And it also, you know, what we know, for example, is that 10% of clients or potential clients, you know, access residential inpatient treatment, you know, whereas there's been a shift and move towards early intervention and community awareness and prevention community-based programs. All right, so that is just kind of a informatory for your information. All right. So just to unpack what this means, you know, in terms of the different levels, the prevention level, which refers to or includes outreach and awareness. And this is very much provided to families and young people who are at risk, you know, of using or experimenting, you know, with substances. And the whole focus there is to develop people's resilience, you know, against substance use, abuse, or addiction. So it's about, you know, raising awareness, educating people, doing psychoeducational programs, educating people about, you know, the dangers and the harm of substance use. And as we noted from Devon's presentation, it can have a profound impact, you know, on particularly the brain functions, emotions, and behavior. Okay, so the outcome for prevention level of service delivery or interventions is also the outcome there is very much the target groups or people are prevented from becoming chemically dependent. You know, that's the outcome for that kind of programs. And it includes, as I said, awareness raising programs in schools, in residential facilities, in shelters. It can even happen there, you know, where you raise that awareness. Educational workshops, psychoeducational workshops or programs. So the main idea is for that to be aware of early detection and to obviously link the person or particular person affected, you know, to resources. So the prevention program very much is aimed at reducing and preventing the harmful effects of alcohol and drug usage. And I think, you know, this is one of the first kind of level of service delivery, and it can happen in various sectors, and it can happen, you know, even in shelters, as I said. A lot of NPOs, NGOs, organizations, wherever, because of the scope of the problem, as we heard in the previous session, that it is very valuable and useful to prevention services. Okay, so the next level is that of early intervention, and is also referred to as the harm reduction, you know, level. And this level of service is provided to assist those using substances to remain within their families and communities, right? So that means that we try and keep or maintain the person affected within the family and community setting in order to, as long as possible, you know, in order to maintain some form of functionality, right? Whether it's in the family, in the workplace, or, you know, in schools, or, you know, wherever people find themselves. So that it is a case of there's some form of intervention that can happen and the person lives and works and stays within that family community context. All right, so the outcome there is very much to reduce and minimize the harmful effects of alcohol and drugs and substances, other substances. And as we know now, we also have licit and illicit substances, right? So it's legal and illegal substances. So very important matters that we have to also comply with in this level of intervention or service is that of rights and legislation. And that is very much the, you know, referral or admission to an early intervention program is also aligned according to legislative policies and procedures, but also, you know, the client's rights has to be acknowledged within this context. So, and I think the previous conversation we had was the whole thing about, you know, people have a right to access services, right? And So that is where Devin suggested that we need to question, we need to keep people accountable, we need to insist, we need to facilitate that accessibility, you know, to these services, and hence the fact that we can use and refer to legislation, especially that section 33, looking at of the acts, the rights of the clients, you know, need to be incorporated in this whole process. Of course, non-discrimination. So everyone and all are available. Admission can be available to all suitable clients, despite race, ethnicity, gender, culture, ideology, sexual orientation, language, and HIV status. So, people cannot be excluded from any program, you know, because of those kind of diverse factors. Also accessibility. So in order to access the service, as we know now that, you know, the assessment is very important, the screening tools that's being used and screening processes, you know, can guide the kind of urgency or the stress level that either the client, the family, and or community actually experiences in order to facilitate that access, whether it is to a early intervention program or an inpatient treatment program. So I think that's very, accessibility is very key in terms of, and that assessment that was referred to earlier on is very much the guiding kind of tool that will determine, you know, where and what level of intervention is required for that particular person having a challenge, or family having a challenge with the particular person and the substance use disorder. So also exclusion, in the sense that, you know, nobody can be excluded, but there are some various facilities, treatment facilities have inclusion and exclusion criteria, right? For example, the whole issue around heroin usage, but that should not prevent the person from being admitted. However, the person must just be referred either to a particular tertiary level institution, basically means a hospital, a tertiary level hospital that can provide or a facility that can provide medical treatment, you know, to manage the side effects or withdrawal symptoms. So the main point about exclusion is that no client must be turned away unless you can actually make recommendations and or referrals to other treatment facilities or resources. Okay. Then we're talking about the treatment and or statutory level of service delivery. And this is very much focused on the provision of services, and intervention is very much focused on providing services for substance dependent persons. Okay. Can you see where the person is dependent on the substance? And this outcome is very much the person is admitted to an inpatient treatment facility or center according to the statutory provisions or legislations, and that include voluntary and or involuntary or you know, committal processes. Any questions from people in that regard? Just looking at the 3 levels of treatment in terms of prevention, early intervention, and statutory. Any questions or comments? Okay, nothing so far. All right, we're moving on. So in terms of the continuum of care treatment plan, you know, that is very much, you know, a model or intervention strategy that is used, can be used either for the early intervention program, but primarily for the inpatient or statutory treatment interventions. So the client actually goes through a client assessment process, and that includes a comprehensive holistic assessment, which is also, we use the biopsychosocial assessment tool, and that would actually just give you a very kind of comprehensive understanding and overview of the presence of the problem, you know, severity of the problem, and also just guides in terms of the level of functioning, in terms of whether there has been some significant drop or disturbance in various levels within the client's functioning in terms of social, emotional, physical, spiritual, occupational, you know, so it's quite a comprehensive, detailed assessment, and that assessment can, you know, sometimes take up to 2 hours, or sometimes depending on the client's kind of commitment or availability, as well as, you know, motivation to participate in that process. And of course, once that client assessment has been completed, you know, together with the client, and of course, as social workers, we have to establish a therapeutic alliance with the client, you know, in order to engage and you know, get into the treatment process. And there we use another tool, which is called the IDP, the Individual Development Plan, and that is very much the treatment plan. And together with the client, once you've established that alliance, you know, to promote the client's participation, motivation, and recovery, you know, to embark on that whole journey, right, of treatment and recovery. And I think that is a journey, as we know, can take some time. There will be relapses in between, but it's a journey that will have to include the client, as well as his family members, as well as other support systems or structures, either in the family or in the community. And that is a very, very important process in order to, you know, embark on this treatment with the client. And also important factor there is that of pharmacotherapy and medical care. And this is very, very significant and important, and very much depends on the severity of the substance use disorder of the client. And that pharmacotherapy and medical care is very important in order to manage withdrawal, as well as physical and or mental health needs that the client might have experience. And I think what a lot of you have alluded to earlier on is that, you know, a lot of the clients that comes, women that who comes into the shelters have either physical and or mental health challenges, right? So that's a very important component when one actually, you know, embark on the treatment program or intervention for substance use disorder. And then also it requires a structured treatment or rehabilitation program or plan. And there that requires a formal program, right? Structured, and these structured treatment programs must comply to the norms and standards as stipulated and guided either by the legislation. And as we heard earlier on, that DSD is very much the custodian, you know, who monitors and evaluates the compliance to this particular process. And formal program, which includes a kind of almost the treatment plan, the methodologies, the intervention models, you know, whether it is MI, motivational interviewing, whether it's CBT, cognitive behavioral therapy, or whether it's DBT, dialectical behavioral therapy, whether it is the 12 steps program. There's just a range of treatment modalities, you know, that can be applied, and each facility, or you know, people choose the particular best practice model, you know, but it is very important that when one manages substance use disorders, that there are particular best practices, you know, and that needs to be applied. Also, the individual, family, group therapies and counseling must include that. As we know, it does require not just to work with the individual or the affected person, but also the family, and as well as in a group context, developing and having that peer support. And as we heard earlier on, that person embarking on this journey of recovery, it's a very intricate, complicated, and difficult journey. So that kind of group support and group processes is very important, but it's also part of the therapeutic interventions that will help guide the person through this recovery process. All right. And then, of course, also the structured treatment program can or must also include life, social, and vocational skills programs. And it can also, sorry, I just need to go back. Also can include also spiritual guidance and programs. And then, of course, your daily activity programs, which focuses on the kind of real-time, daytime activities in terms of how the person is spending time, and also just the various activities in terms of either to feed into some of these individual items, for example, life skills programs, social skills program, or vocational skills program. So those are very kind of detailed processes that forms part of the continuum of care kind of treatment model, and it helps the client helps you to manage the client more effectively. Okay. Then, of course, we're talking about the release and aftercare program, very important, and that is significant when part of the continuum of care treatment process, and in that, you know, the focus is very much on that effective transition and integration or reintegration of the person who was going through the treatment program, to reintegrate them back into the families, workplaces, or communities, or schools. And then also the referral or linking the person to a referral resource or self-help group, for example, AA, NA, Narcotic Anonymous. There's quite a bit of self-help groups established in various communities, and that also helps to help support the client, you know, in terms of relapse prevention, as well as, you know, maybe a sponsorship or just helping the person to maintain sobriety, you know, and cope and manage. And as we know, relapse is very much part and parcel of the treatment program or plan. So it is can be expected, anticipated, and I think the whole focus is there, you know, to help the client how to manage that relapse in the event of it happening. And a very useful tool that we use, you know, is about also doing psychoeducation around it, and also just kind of a constant monitoring, looking at maybe regular drug testing, telephonic tracking. There's various ways and means how to support the client in that kind of client who's in recovery, you know, for to prevent relapse. And then, of course, recovery is a lifelong journey. It's a long process, and it requires a combination of family support and other resources. And as we heard earlier on, also about the recovery capital, you know, and where and how we need to extract what's important, and each client is different, but it's a also realistic process which we need to monitor and engage with, in the sense that, as we know, recovery is a difficult process, you know, and that the client needs to stay motivated, supported, and, you know, engaged in this process for a long time. Any questions there or comments? No CPU? Any comments from you or questions? Okay. I see we've got about 10 minutes left, right? So just to let you quickly reflect on today's session. So what we have covered today was that, you know, conversation we had around the challenges, you know, of substance use disorders in the shelters. We also did a very beautiful presentation from Devin around understanding substance use disorders and the context in which it has to be managed. And now we also zoomed in on some of the levels of intervention in terms of where and how, right? We can access the different levels of services based on the presence and or severity of the substance use disorder or problem. So all in all, I would just like to get people as get a sense from people as to what is your lessons learned for today. All right. Thank you. Melanie, if I maybe can get something from you.
Hi, Shaida. I'm still here.
Okay.
Sorry, I haven't been, like I missed most of it early on, especially Devin's
Okay.
presentation.
Mm.
But it definitely was insightful. It seems like we do have at least now a way forward. We know some procedures and steps that we need to take. We also have from Devin, you know, contacts that we could be using in future, which definitely would come in handy. Especially for the shelters who are uncertain of a way to go forward, especially when we have
Yes.
clients who are struggling in the substance abuse sector. You know, there's definitely a way forward now for us, which we definitely appreciate, and we thank you for that.
Yeah, thank you.
I see Manisha is unmuted. I'm not too sure if she's just unmuted or if she has something to say.
I just check in there, Melanie. Can you communicate with her? All right. Let's hear from Mabel. Mabel, any comments from you? Okay, I'm just quickly running through names. Okay. Rachel?
Shaida, yes,
Yes.
thank you very much for that. It was very informative. The advice, especially like I said, with the involuntary admission for adult
Yes.
children, that piece of advice is very advisable. Thank you very much for that. Yeah, as the challenges, but also what we discussed, and then the intervention, the last part, Shaida, there was this one question that you managed when that you said about you can't turn a client away. Ne?
Yeah.
Even if, does that mean even if the policy is that clients that is positive for heroin, if you can't get them into another facility, what do you do with that client? Because we can't, our center's policy is that we can't take it in, but we are
Yes.
struggling to get it into another facility. So at the end of the day, what do you do with the physical woman?
Yes. You know, of course, that is where, you know, that there's still a lot of conversations that needs to be, that needs to happen within the GBV or the, you know, shelter sector, if I can put it like that, in terms of, because there's two levels, right? One, it is the shelter where obviously you have your own criteria, admission criteria, right?
Yes,
And
yes,
if the
that's right.
client does not comply with your admission criteria, the social worker, who they are versed in knowing where the resources, referral resources are. They should be versed. Let me rephrase that. Whether referral resources are, whether it's social,
Yes.
whether it's health, whether it's whatever.
Yes, yes, I do
that
understand that, but then the problem is that you struggle to get them into that centers where we.
Yeah,
That
but
is the
listen, it's not necessarily just a rehab center that's required. You understand what I'm saying here, Rachel? Hence my presentation now that I've done, you know, as I say, there's different levels of service delivery, right? And in that context, based on what you were talking about now, say if a client comes there and you detect, hey, here's heroin, né? That client must be referred to Stuckland Hospital, for example, if it's in the Western Cape. Ne? There must be a liaison or collaboration between you and that Stuckland Hospital to see for that, to see, you know, for possible admission, right? But also there are community-based organizations, for example, the Sultan Bahu Center here in the Western Cape, right? They provide kind of that kind of detoxification services as well. For example, Sultan Bahu has 3 centers, one here in Nova Park, one in Mitchells Plain, and one in Bellville, right? So they can issue, they have a license, they can issue some form of medication and monitoring, you know, that can help to manage that particular client who's having some problems with I mean, heroin, right?
Yes, yes,
So
yes.
that can be referred, for example, to Sultan Bahu Center, right? And there is where they do that kind of community-based early intervention service. You hear what I'm saying here,
Yes,
right?
I hear what you're
So
saying.
they can even motivate and or prepare that client for admission to a shelter. You understand what I'm saying here? Ne?
Okay, all right.
Because we have, so that is that point that you're talking about, you know. And the third point is, Rachel, if, for example, that is not an option, you take the client can go to a medical, like the secondary hospital facilities, right? Which is your Victoria Hospital,
En de Grootskies, ja.
not Grootskies, your tertiary, you go to the Vanguard, you go to Somerset Hospital. Point being that you need to know your resources and the levels of care that is provided. I think that is sometimes the big problem, where we don't know the severity of the problem and we don't know where to refer the client to. Does that make sense?
It does. And thank you very much for that information because it will really help with the
Miriam,
addiction.
I heard your
Ada,
voice coming in here.
yes, because I wanted to come in a long time ago. We do sit
Okay.
with this kind of problem, and yes, the social workers are aware of the whole referral system like you described now.
Pathways, yeah.
And we do follow that. And I must say, DST's also been quite helpful. You know, if we are stuck with somebody, at the end of the day, we can refer to them, and they will see that the person gets adequate care, whatever. But I think also what Rachel probably was raising, that we do sit with that kind of problems sometimes, and even trying to follow the right referral pathways, we struggle because sometimes we're getting flack from the community health center, and that's where you start. And then they're supposed to admit the person for 72 hours. We're struggling to have that happening. We did speak to the MEC recently around a proper referral pathway.
Yes.
And then because Victoria and Grootske are refusing us point blank at the moment now. They're saying, no, you have to go through the proper channels. Whereas, you know, you and I have been working in this field for a while, and it was so much easier before. So we do struggle, we do know the pathways. And I also just want to add, also again, thanks to you and to Devin. Devin, it was really fantastic listening, and it's always good to regurgitate all those things. Yes.
And things
also,
change, man.
Yes.
Things change.
No, but the other colleague that was sitting with me, I could show her in our folders that we do use the same tools, you know, and we do use the
the assessment tools.
The best practice models we've got, we do the IDP and all that, and we even introduce that into the shelter now. So we use the IDP, the biopsychosocial. It helps with your assessment. It helps with what you're going to treat the client with, or whatever.
Management, of your client.
But this, what I'm saying, this is exciting because it makes me realize that we also have to gather the clients together and educate them, you know, around their children, about their colleagues, their friends, whatever, around raising the awareness of substance abuse. We know it's huge in the Western Cape especially.
Exactly.
So we need to be talking much more, and maybe we should also be talking to our other staff members as well, so that they can understand where we're at and what are the methodologies that we are using, although they're not going to use it. But I think it would be wonderful for them to understand, you know, what it is that we deal with when we're treating the clients, and we'll be going with all this.
And you know, Miriam, thank you for raising that, you know, because as we know now, substance abuse is a pandemic. Someone said it earlier on, ne? It's the pandemic currently. There's always been a pandemic in South Africa. So at the end of the day, that different service delivery can happen in your shelters. You can do prevention services, ne? Where you do that awareness raising and education. You can do some level of early intervention, you know. And I mean, you luckily for Sarki Bartman, you have a structured treatment program, you know, which means you have a statutory, you can have, it's a structured treatment program, but it's also a statutory form of service. But in your case, most of your admissions are voluntary. You understand what I'm saying?
Yes,
but different levels of intervention can happen in your shelters. It's not just, it's not, you need to, of course, incorporate it and see what is the feasibility of it, and slowly introduce it into your treatment program, whether it's in your shelter program or a specialized program that you have in the place. All right, thank you for that.
I just want to add also, we one of the other community facilities that we use a lot is the Matrix. Our drug our rehab centers got a very good partnership with them, very active partnership, and we also have somebody coming in on a weekly basis that are dealing with the STEP program, somebody that takes them from NA. So that happens weekly, and there's detailed reports and whatnot involvement. It's really excellent, because when the clients are then discharged, they've already got that connection and they know exactly where to go, and they feel comfortable about going there regularly. I think that's good practice in the recovery, actually.
Absolutely. And you know, that is what we refer to as that continuum of care model. Services don't stop. You need to connect the resources out there. And maybe a tip from my side is that all shelters should have almost like a database, and it's easily accessible. You can just tap into DSD's substance abuse directory, and you will know exactly where are these services, different service levels and organizations who provides the different levels of services. That is why I thought it was useful for you to know that information. So that when you have a problem, you can refer If you can't manage it internally, you refer. All right. So thank you for that.
Thank you.
Thank you, Miriam. Ladies and gentlemen, I haven't heard any gentlemen speaking yet apart from Devon, but I know there are a few here. Thank you very much. And I do hope that you have found value in this presentations today. We thought that it's, when one talks about GBV and substance abuse, it's two different topics and social problems on its own. And in order to understand the one first needs to understand the other, right? And I think you are very versed in GBV, VEP, so I am not gonna rehash that part. And that is why I felt that it's important for us to unpack what is the substance abuse and substance abuse disorders, or SUDs, that we refer to. Okay, new terminology maybe for some of you, old terminology for others. However, the point being that it is a challenge that is surfaced in the shelter sector or movement, or in shelters, and that it is something that cannot be ignored because it affects the work, it affects the management of the client, it affects the treatment of the client, and it also requires an approach, to address the issue. It's not going to go away, so we have to deal with it. We need to acknowledge it firstly, we need to talk about it, and we need to decide how we're going to deal and manage it. All right, so that is all from my side for today. Our next session will be on the 28th of July, same time. And we'll do the same via virtual Zoom meetings, which Melanie, thank you for setting that up. She's already sent the links, and she's also recording. And note, after this next week's session, we will make all the presentations available and forward it to Melanie, who will distribute to all participants. And then we'll also issue people with almost like a attendance certificate. So thank you from my side, everybody, and thank you for your participation. And Melanie, maybe last words from you. Thank you very much.
Thank you, Shaira. Once again, thank you to yourself and to Devon for very informative session today. I know we are all walking away with a lot more than what we had earlier. It really was informative. We thank you so much for your time and your effort that you put into the presentations. And we look forward to next week's one as well. Like Shaira has said, recordings as well as presentations will be sent out after next week's workshop, as well as an attendance certificate. So it is very important for you to send through your information with your name, surname, and organization, so that we can then record it and then send out those certificates. But to all, thank you for attending and joining us at this workshop, and we hope you have a good and blessed day further. Shaira, you muted?
Asan, let me just put on my eyes so I can see. So thank you very much, Melanie. I would like to see your face though, Melanie.
I was
Or
about to say, it's lovely to see you.
Are you in your pajamas? Hey?
Oh no, I'm actually in the office. I don't look the best, but I'm in my office.
All right. Okay, nice seeing you. So
Yes.
go well, and we'll
And you
communicate,
too.
the two of us, if
Definitely.
necessary. Thank you.
Yes.
Bye-bye.
Thank you. All the best, everybody.
Bye.
Bye.